नमस्ते सर।
नमस्ते।
आज लोगों ने ज्वाइन नहीं किया, पता नहीं क्या हुआ। आज तो 4 minutes are left, 3 minutes are left, but
देखते हैं।
हम्म तो मोनिका भी है। मोनिका शायद एंटर हो रही है। हाय डॉक्टर मोनिका। हाय डॉक्टर मोनिका, कैसे हैं आप?
ऑल फाइन मैम, कैसे हैं?
बस।
गुड इवनिंग
आप तो
सर।
गुड मौसम में पहुंच गए, हम तो स्टिल इन द टू द कोल्ड वेदर ही है। जस्ट
मैम रुकिए, सबको फोन करते हैं, 5-6 बज रहे।
हाय डॉक्टर नीता, कैसे हैं? यू आर म्यूटेड। नमस्ते राजेश सर।
Very good evening. Very good evening.
All the time seeing your videos and your classes and all.
Nice. Thank you so much.
So much of work on endoscopy, sir. Really, you are a pioneer in everything.
My pleasure. Thank you for the nice words.
हेलो मैम,
Yes.
पुष्पा मैडम इज जॉइनिंग इन 1 minute. राजेश सर हैज ऑलरेडी कम.
अच्छा, हाँ। हाय दीपिका। हाय दीपिका।
हाय हाय।
अगेन ठंडी
हाय।
ठंडी। मैंने कहा तुम
ठंड तो बहुत हो
बाकी
रही है
लोग।
यहाँ पे।
हाँ, बाकी लोग तो सब प्लेजेंट एटमॉस्फेयर में पहुंच गए, अपन ही कोल्ड में है।
हाँ, अपन ही कोल्ड में है। गुड इवनिंग सर।
Very good evening.
Good
गुड
evening.
इवनिंग डॉक्टर राजेश जी।
Very good
हाय डॉक्टर
evening.
मोनिका। डॉक्टर प्रांजल, गुड इवनिंग।
Good evening. Good evening, Rajesh sir. Good evening, everybody.
गुड इवनिंग प्रांजलि मैम, गुड इवनिंग.
Good evening. Hello, Monica.
मैम हाय मैम, दे आर 2 Monikas here.
Oh, hi.
Nivedita has also joined.
Rajesh
Hi
sir.
Nivedita. How are you?
फाइन.
Rajesh sir got time to come from his OT.
That is,
Early wind up.
I was still wondering कि sir is doing so much of surgeries, whether he will join or not.
Early wind up.
Good evening, Dr. Monica, Dr. Deepika, Dr. Pranjal.
गुड
Hello,
इवनिंग।
Nivedita.
निवेदिता, है ना,
Yes, sir.
मोनिका स्क्वायर लगा दिया करो, पता लग जाएगा दोनों मोनिका इंक्लूड हो गए।
हाँ, मोनिका स्क्वायर। हाँ,
Monica Squares, Monica Square. Rajesh sir, good evening.
Very good evening.
राजेश सर का अकोला वाला फिर से शुरू हो रहा है। हमारे colleagues आ गए।
Yes, courses keep on happening.
पटेल सर, તમારી પરમિશન હોય તો સ્ટાર્ટ કરીએ. ઇટ ઇઝ 6:01.
yes.
રાजेશ સર ઇઝ
Oh,
देयर.
yes. Oh, yes.
પુષ્પા मैडम इज जॉइनिंग इन अ मिनट्स
Oh,
टाइम.
yes.
Good
Welcome,
evening, Patel
Rajesh.
sir.
डॉक्टर पुष्पा ज्वाइंड, मैडम हैज
Namaste.
ज्वाइंड।
हाँ, या. And I spoke to Rohidas sir also. He is also joining, sir.
ओके।
Rajesh Babu, welcome.
Thank you so much for the kind invitation to be a guest in your program.
Thank
I'm
you,
looking
thank
forward
you.
to it.
Thank you.
Darshan, please give us the countdown so that we can start.
Yes, ma'am. Yes. Good evening. So, welcome all the esteemed faculty members and delegates for this COR Connect webinar. I, Darshan Wagela, on the behalf of Corona Remedies, I would like to welcome each one of you from the bottom of my heart. So, I am like starting the session with the prayer. Just a minute. Huh? I'm just sharing the sound as well.
Hello,
So, I'm handing
am I
over
audible?
to Monica, ma'am.
Yeah, yeah.
Yeah.
Yeah, you are.
Thank you, Darshan, for the prayer song. I welcome all the August gathering and the esteemed faculty members and delegates to the 215th episode of the Happy Learning Master webinar series with Akola, Amravati, Buldhana, Pusad, and Yavatmal societies. The theme for today's webinar is hypertensive disorders in pregnancy, and we have our esteemed speakers who will be covering the topics right from the pathophysiology to the management case-based. The program director of this important webinar series is none other than Dr. MC Patel, sir. Sir has been the vice president of the FOFSI. He is a medical legal consultant and the go-to person in all our medical legal emergencies throughout India. Sir is also an active Rotarian and he operates in the Northeast free of cost every year with the camps. Sir has been diligently doing these webinars since the time of COVID. Hats off to your persistence, sir. And I would also like to thank all our coordinators, Dr. Monica Gupta, Madam, Dr. Deepika Lugani, Dr. Shatabdi Dey, Dr. Nivedita Datta, and Dr. Megha Kamlapurkar for joining hands and helping us to carry out this webinar. I now formally welcome Dr. Patel, sir, to please officially give his welcome address.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all to this one more Happy Learning Masterclass web series webinar. And today joining Society Amravati, Akola, Buldana, Pusad, and Yavatmal. I welcome Dr. Pusma Jungare Madam. She has kindly consented to be chief guest. Of course, she is always with us in any of our academic activity. Welcome, Madam, and thank you for sparing time. I also welcome Dr. Rajesh Modi, good old friend in Foxy. Sorry. He has kindly consented to be a guest of honor to bless the webinar. He is a very busy person, but he has spared time for us. Thank you, Rajesh, for the same. I also welcome Dr. Rohidas Chavan, sir. He has also kindly consented to be guest of honor. Thank you, Chavan, sir. I also welcome all the learned chairperson, Dr. Suvarna Bopare Madam from Akola, Dr. Suyoga Panath from Amravati, Dr. Sadanand Ingle from Buldana, and they are going to chair a very interesting session to be taken by Dr. Nithika Raghuvanshi from Akola. She is going to talk about prediction and prevention of hypertensive disorders in pregnancy and preeclampsia. I also welcome one more set of chairperson, Dr. Suhasini Bope Madam from Pusad, Dr. Sital Bhandari from Pusad, Dr. Arun Rathi sir from Akola. They are going to chair very interesting session which is going to be covered by Dr. Mulali Dhole Madam from Amravati, and she is going to discuss management of hypertensive disorders in pregnancy and preeclampsia. One more pair of chairpersons, Dr. Alka Kuthe from Amravati, Dr. Girish Mane from Yavatmal, Dr. Paresh Gandecha from Yavatmal, and Dr. Poonam Belokar from Amravati. They are going to chair a session which is covered by me and legal issues in high risk pregnancy. I also welcome two learned moderator, Dr. Sneha Buyar from Yavatmal and Dr. Pranjal Sharma from Amravati. They are going to discuss real happen cases in our day-to-day practice in hypertensive disorders in pregnancy and preeclampsia. And in that very interesting panel, expert comments will be from Dr. Rasmi Kahar from Amravati. I also welcome all the panelists, Dr. Archana Rathod from Yavatmal, Dr. Varsha Chavan Madam from Yavatmal, Dr. Jagruti Bharat Shah from Akola, Dr. Saili Jahangir from Amravati, Dr. Manjushree Boop from Amravati, Dr. Lalita Lokhande Madam from Amravati, Dr. Apurva from Amravati, Dr. Meena Agarwal from Pusad, and Dr. Nita Keshwani Madam from Yavatmal. I also welcome all the President and Secretary of Member Society who have joined this webinar and all the delegates. And of course, my team, Dr. Monica Omardan, convener for this series, and all other coordinators, Dr. Monica Gupta from Alwar, Dr. Nivedita Datta from Bokaro, Dr. Deepika Logani from Delhi, Dr. Satabdi Day from Siliguri, and Dr. Megha Kamlapur from Gulbarga. So this time we have decided to discuss hypertensive disorders in pregnancy. So from prevention, prediction, and how to manage, we are going to discuss. And we all know it is one more the culprit as far as maternal mortality rate is concerned. And we being an obstetrician directly concerned to check maternal mortality because WHO and Government of India has given us a target by 2030 our maternal mortality rate should be less than 70. It should be 67 or even less than that. Of course, there are few states in southern India, they have maternal mortality rate near 30 or so. But at the same time, few are the states in north and particularly in northern eastern area, which is still MMR is near 200. And of course, it is a matter of worry, matter of concern directly. So that is why we are discussing this type of cases, this type of topics to update our obstetrician friend and ultimately to be helpful to our patient to check MMR and IMR. So without wasting much of your time, inviting you all, welcoming you all to this webinar. Thank you very much.
Thank you so much, sir, for allowing us and to convene and coordinate this program. I now take the privilege to introduce Dr. Pushpa Jungare, Madam, our chief guest for today. Can we have the slide, Darshan? Madam is a professor and the head of the department at PDMC Amravati. She has been a member of the undergraduate and postgraduate board of studies of surgery and allied subjects at MUHS. She's also the faculty of medicine at MUHS. She's the first visiting professor sent by Foxy to Cuttack Medical College, Odisha as a PhD guide. She has been a mentor to many of us at AMOX. She's been a faculty at various national, state, and zonal conferences. Madam has been the past president of the Amravati OBGYN Society, the organizing secretary of the State Conference of AMOX in 2005, the chairperson of the same at AMOX 2020 at Amravati. She's also the peer reviewer of Journal of OBGYN of India. She has popularized NDVH in the Amravati region, and she has been instrumental in establishing the first human milk bank in the central India at PDMC in Amravati. She's been awarded the Podhakar Sanman Award in 2012-13 for her work
I
in
think Dr. Monica,
positive patients. Ma'am, the list
you have
is
said
endless,
enough about me.
and we are in awe of your
Please.
achievements. It is indeed a blessing to have you with us for this webinar today. Over to you for your words of wisdom, ma'am.
Okay, first of all, I would like to congratulate Dr. Patel and his team of coordinators. He is doing a mammoth work of this masterclass. 215 means just imagining it that this is going on over weeks and years, I would say now years together. And it is really helpful. The topics that he chooses, they are really very much practical topics, and it is very much useful not only for the students, the faculty in medical colleges, but most important, the practitioners, because if they want to keep updated in their busy life, these are the ways by attending this such master classes. All this information is put concisely and within 1 to 2 hours. Most of the information with all the updates and all the things, they are given ready-made to the audience. So I again congratulate. And today's topic, that is hypertensive disorders in pregnancy, it is really a quite common problem that we face in our day-to-day practice. And it is important we time and again we brush up what is new in this and what are the latest trends in management, and equally important is the prevention. So this is going to start prevention, and then gradually all the speakers, learned speakers, they are going to talk on this. So really, it would be very helpful for everyone. And this panel discussion and the medical legal problems, that is the mainstay of this, because almost every complication which a pregnant woman faces, there might be some or the other repercussions as far as medical legal cases are concerned. So we should have medical legal aspects well covered. That is, simply knowing the subject well, we are able to treat the patient well. But sometimes there are some unexpected problems which might crop up, and later on, we may not be even expecting some medical legal problem, some complaint from the patient. Many of the things, they may not be under control. And then we face this medical legal problem. So it is always better to be prepared with every topic. Dr. Patel ends with this medical legal discussion, and that is the best thing in this master class. So I wish him all the best in his future endeavors also. And I give best wishes for this masterclass, 215th. Congratulations once again.
Thank you, madam, for sparing time for us. Of course, you are always with us in any of our academic activity. Welcome, madam. Thank you.
Thank you, ma'am. Thank you for gracing the occasion. And I now request Dr. Monica Gupta, madam, to please introduce the guest of honor.
Thank you, Monica, and thank you, Patel sir, for the opportunity. Please put the CVs of guest of honor.
And Darshan, I request you to
It is
please
our
stop
pleasure
sharing
to
the
have.
slides when the speaker speaks so that we can have a full view of the speaker. Once the speaker is introduced, please stop sharing the slide after that. Huh?
It is our pleasure that we
Okay,
can
madam.
have Dr. Rajesh Modi as a guest of honor in our webinars. We have already, everyone has seen his videos, his classes for the endoscopic surgery. He's a name. He's a renowned person in the field of endoscopy, and he has invented so many of the new techniques. He has introduced day care laparoscopic hysterectomy, Dr. Modi aqua dissection technique, Dr. Modi's recanalization technique and instrumentation set, Dr. Modi's signature needle holder for lap suturing, and he will do in the few more years to come, he will have a more list of his inventions, and he has conducted many fellowships and short courses for the gynae endoscopy, and he was a vice president of Foxy 2017, and we are really honored to have you, sir, in our with you in our webinar. Over to you, sir, for your kind blessings.
Thank you, Dr. Monica Gupta, for the nice introduction and the kind words. I am pleased and happy to be here with you, especially to Dr. MC Patel. My sincere best wishes for the upcoming elections also. not only as a close friend of his over the past so many years in Foxy, but also as the president of Akola OBGY Society. We definitely give you our best wishes and hope that the results are favorable. And I am really thankful to this opportunity, though this is not exactly the field where I am personally involved in obstetrics. I am restricting to the endoscopy part. But as a good friend and a well-wisher, it's always a pleasure to be a part of whatever programs you are doing, especially when you are arranging it for our region in this region. It's nice to see familiar faces on the faculty list. Dr. Pushpa Soman, she was just now here with us. Dr. Nitika from Akola is there, Arun Rathi from Akola is there, and our other colleagues from this region. We really look forward to interacting in person also. Apart from my best wishes, I take this opportunity as a president to invite all of you to visit Akola during my tenure in this year. Please feel free to drop me a message and we would be happy to include you in one of the multiple programs that we are planning this year. And Dr. Monica and Dr. Monica, thank you for the wonderful introduction and the opportunity. Thank you all.
Thank you, Dr. Rajesh, for sparing time again for us. You are always with us. You are a good old friend. Thank you for all the wishes also.
Thank you, sir, for introducing laparoscopy to every nook and corner of India. You were the pioneer to introduce laparoscopy workshops in theaters. So we didn't know and we couldn't think that this could be possible without your vision. So thank you so much,
This
sir.
year in Bhaskar's term under Foxy banner, we are going to do one PVR program in Nagpur, 31st August and 1st November. So all of you are invited to be a part of my program team.
Okay.
Thank you, sir, for sparing your valuable time despite your busy schedule. We all know you are all the time in the theater. We are now our next guest of honor is, please put the CV. Next, Dr. Ruidas Prabhu Chauhan. He is a professor and HOD in Yavatmal and Akola medical colleges. Hello. He has got a special interest in management of high-risk pregnancy, NDVH, ultrasonography, endoscopy, and he's a founder secretary of Yavatmal or OBGY Society, and he was a past president in the same society and past chairman of IMS. He was a UG and PG teacher, past superintendent, having a 25 years of experience of teaching UG and PG students, many national and international publications, and received MS Signature International Award, and he is currently working as a special officer on duty at Super Specialty Hospital of Sri VNGC Yavatmal. Over to you, sir, for your kind blessings. Rohidas, sir.
Thank you, Monica madam, for kind introduction. Actually, I'm now not working in the department of gynae, but Rajesh and me, both of we are from the Mumbai KM Hospital, the GS Medical College students. But
Yes.
I am working in the government medical college only. But Rajesh is a really great and good person in the laparoscopy. He has developed his own name and fame in the society. So greatness it is. Actually, thank you that I am also included in this webinar series. And thank you for the, I shall congratulate MC Patel sir. He remembers and he personally contact each and every member of the society. And I would give this in future best of luck for the sir and keep it up. Thank you.
Thank you, Rohidas sir, for kind words and good wishes also. You are always with us. Whenever
Sir.
I have called you, you have simply said, yes, I am there.
Yes, sir.
Thank
You,
you,
sir. Okay.
Thank you, sir, for your kind words. And now over to Deepika Logane for the academic session.
Yeah, so good evening to all. We will be now starting with our scientific session. And session one, the topic is prediction and prevention of PIH. And it's my honor to invite the chairpersons for the first session. So can we have the CV, please? The first CV. It's my privilege to introduce our first chairperson for this session, Dr. Suvarna Bhopale ma'am. Madam is the director of Shri Sai Hospital, Akola, and is a cosmetic gynecologist. She is the secretary of Obs and Gynae Society of Akola and is also a member of the Public Awareness Committee, actively contributing to community-oriented women's health initiatives. Ma'am, we are pleased to have her chair this session today. Our next, can we have the next slide, please? Our second esteemed chairperson for the first session is Dr. Suyoga Panath, Madam. Ma'am is senior consultant OBGYN and has served as the president of Amravati Obs and Gynae Society. Ma'am is currently the chairperson of the EMOGS Medical Legal Committee and also serves as the West Zone coordinator for the Ethics and Medical Legal Committee of FOXI. Ma'am is a recipient of numerous awards and is widely respected for her leadership and work in the field of ethics and medical legal aspects of OBS and gynae practice. Welcome, ma'am. Our next chairperson is Dr. Sadanand Ingle, sir. Sir is the president of Buldhana Obs and Gynae Society. He's a consultant obstetrician gynecologist at Ingle Hospital, Khamgaon, and is known for his long-standing clinical practice and commitment to providing quality women's health care in the region. We are very pleased to have you with us, sir. And could I now request our chairpersons to introduce our speaker for the first session, Dr. Nitika Raghuvanshi, madam. Uh, could we have so Dr. Soyoga, could you do the
Yes,
honors, please?
yes. At the outset, I would like to thank Dr. MC Patel sir and especially Monica also for giving me this opportunity to be a part of this important webinar, which is based on the global problem of PIH. And we all know that it's one of the most common medical disorder complicating around 10 to 15% of pregnancies. And including this topic in this webinar, it seems really very important since it is associated with lot of maternal as well as fetal complications. So I have the privilege to introduce Dr. Nitika, but I need the slide.
Yeah, he's just giving this, just sharing. Madam, can you
Uh,
see?
yes, yes,
Yeah,
sure.
yes, ma'am.
Dr. Nitika Raghuvanshi, madam, has done her MBBS from Netaji Subhash Chandra Bose Medical College, Jabalpur, and she is MS from MGM Medical College, Indore. She has also done her DNB, and she has received Dr. Reddy's Gold Medal for outstanding performance in MS at MGM Indore. She had done various training in colposcopy as well as laparoscopy, has done FCCS course in obstetric critical care. At present, she is associate professor and unit head in GMC Akola, and she is an MUHS approved UG as well as PG teacher, MMC accredited speaker, and she has a great interest in the field of high risk obstetrics, critical care, and preventive oncology and colposcopy. She has presented various papers and posters at national and regional conferences. So I would like to request Dr. Nitika madam to begin with her talk on prediction and prevention of PIH. So over to you, madam, and thank you very much again.
Yeah.
Thank you very much, madam, for that kind introduction. Good evening to all. At the outset, I'm thankful to Dr. MC Patel, sir, and Dr. Monica for making me part of this webinar. I know sir since long, and I know that his dedication and commitment.
तेरा वो साउंड प्रूफ है ना बेटा मैं ऐसे ही बैठ के कर रही हूँ साउंड प्रूफ है ना तेरा
This 215th webinar itself shows the degree of commitment that sir is showing to us. This consistency is really commendable. His consistency is really commendable. And the luxury that we are all having to learn from our own drawing room and bedroom, the luxury that he's providing us to update our knowledge. Thank you very much, sir. I also take this opportunity to wish him best luck for his presidential election of 2026. And we are with you, sir, and we know that you will do the best.
Thank you. Thank you.
So I'm sharing my slides. Slides are visible?
Yes, ma'am. We can see
Ma'am,
them.
your slides.
Okay. So today's topic is prediction and prevention of HDP. If you see, every 2 minutes, a pregnant woman is dying because of one or the other cause. And one of the most common cause is the HDP. If you see the demography, therefore is the need for prevention and prediction of this HDP, that it's so common that 10% of the pregnancies are being affected by this. It is one of the leading cause of maternal and fetal complications. And if you see this, that there is very good predictive test which predict this complication or problem around 96% if we apply them properly. So if we have any set of tests which are predicting the problem to 96%, then the disorder should be under our control. So that is what is the aim of today's topic. HDP have a higher risk of future cardiovascular disease in women. So it is not only affecting the maternal part, it is a long-term trauma that they are getting from here. MMR in 2020 and 2022 was 88, and the substantial developmental goal which has been set for 2030 is less than 70 MMR. Though most of the south states, that is Karnataka, Telangana, Kerala, Tamil Nadu, even Gujarat and Maharashtra, they've already achieved it. So this signifies that India is on track to meet the national health goals. And why this has happened, that now our approach has been changed from treatment to prediction and prevention. If you see the predictors of HDP, the first foremost important thing is a history. It's a so simple thing. Whenever we interact with the patient, the first thing that we encounter with the patient is the history. So if you have a meticulous history, especially regarding her previous gestational hypertension, preeclampsia, or if she is dealing with the chronic hypertension, that is the previous preeclampsia and gestation hypertension has not been corrected and now she is with the chronic hypertension. So we should identify these women before they become pregnant. We should also stress on the family history of these patients, especially the history of preeclampsia in their sisters, in their mother, and the history of cardiovascular disease. Should also take a privilege to know about their medical disorders like diabetes, kidney diseases, and nowadays PCOS is a very common thing in the adolescents. So we will be getting the patients who will be already a case of PCOS previously. So they are also at a high risk of diabetes and hypertension later on. Autoimmune issues and heritable thrombophilia. Another important predictor is maternal characteristic. The moment the patient moves into our OPD, by looking at her status, we can have this idea that can this be a case of HDP later on. So this easy is this if we are putting our eyes in it. So if a woman is obese, her BMI is more than 30-35, she is a high risk. If she is a nulliparous who is becoming pregnant very early in less than 19 years of age, or if she is a elderly primary, again she is at a high risk. Nulliparity itself puts her to a high risk category, and multiparity as well. Next thing is certain pregnancies, they also have a high risk association. So we have to identify which are these pregnancies which are going to making her prone for HDP. So if you are dealing with a multiple pregnancy, if you are dealing with the pregnancy of IVF, that is assisted reproduction, these are the cases which are going to have more risk of development of HDP. If the interpregnancy distance is more, that is more than 5 to 10 years, or if she has or she was suffering from gestational trophoblastic disease. Once we have done the part of history taking, then comes the clinical examination and hemodynamic markers. We all are very meticulous in taking the blood pressure. Now, this is such a simple test and it has got a very good predictive value for HDP. What they say is that if you are getting a blood pressure of more than 130/80 before 20 weeks, consider that this woman can have an HDP. Why? Because the secondary wave of invasion, it happens at around 16 weeks. And with the secondary wave of invasion, there should be a fall of around 10 to 20 millimeters of mercury in her blood pressure, which is a very good sign or a welcome sign. If this is not happening, this shows that there is a resistance in her blood flow. And this is the predictor that we have to pick up. Now, if you have to pick up such a minute change of 10 to 20 millimeters of fall or no fall, then you have to be very meticulous in taking the blood pressure. So here are 7 simple steps or tips that one has to remember when they are dealing with the blood pressure of a pregnant patient. The first thing is that you don't have to do much of the conversation with this woman before taking the blood pressure. cuff size should be accurate to her weight and her build. That is, obese patient will need a larger one and a thin build will be smaller. There should not be any clothing between the cuff and the body. Her arm should be rested at the level of heart, and the bladder should be empty. Her legs should not be crossed, and she should be in a sitting position with back at rest and feet are also at rest. If you see every marker, they have a 2 to 10 millimeter mercury change in the blood pressure if they are not being followed. In most of the hospitals and setups, it is the paramedics or the nursing staffs which are taking the blood pressure. So we should sensitize them for this issue, that if they are doing all this, they will be picking up the right blood pressure. The second important thing is mean arterial pressure. This is also a very good marker. If it is elevated to be more than 85 millimeters of mercury, it is a good predictor. And the calculation is very simple. That is, systolic pressure into double of diastolic divided by 3 gives us the reading. Next parameter is an investigation, that is a uterine artery Doppler. It reduced absent or reversed and diastolic flow due to failure of villus trophoblastic invasion, signifies increased resistance in fetal circulation leading to preeclampsia and IUGR. There are different times on which we can evaluate this uterine artery Doppler. The first window, that is 11 to 14 weeks, that is the time of anti-scan. The goal here is to identify the high-risk woman early enough to initiate the preventive therapy. When it is combined with the maternal history and the biochemical marker, it gives a very good detection rate. The second window is in 19 to 24 weeks, where the anomaly scan has been performed. And abnormal finding like high PI, RI, or persistent diastolic notch, they are strongly associated with adverse outcome. The third trimester, where the risk is been found to be associated with detection of late onset preeclampsia and FGR. Now a word about biochemical markers. So there are certain predictors which do have a value in the detection of HDP if being assessed in the early pregnancy. So certain markers, they are increasing, and then they are giving this idea that these patients are at a high risk. But certain markers are reducing. So what are the markers which are increasing? They are the beta HCG level, soluble endoglins, a ratio of soluble FMS like tyrosine kinase 1 and placental growth factor, and fibronectin. While those biomarkers which are decreasing are placental growth factor, pregnancy-associated plasma protein A, and vascular endothelial growth factor. Now, beta HCG is a very good marker in second trimester, that is in between 12 to 20 weeks. The elevated level, they suggest of abnormal placental development and function, leading to ischemia, which triggers the HDP. It's a very cost-effective test and are easily available everywhere. But if you apply this test as a single test, its predictive value is not that good. But when it is combined with other biomarkers and history, it has got a good predictive value. Soluble endoglin, it is released from the placenta, especially under the hypoxic conditions. And it inhibits the endothelial nitric oxide synthase and causes the vasoconstriction, which ultimately results into high blood pressure and proteinuria. Levels rise earlier and higher in preeclampsia, correlating with severity and adverse outcome. It acts as anti-angiogenic factor, interfering with the normal vascular growth. The level of soluble endoglin are generally much higher in preeclampsia, that is in a range of 20 to 50 nanogram per ml. A word about the S-split1 and PLGF ratio. A high ratio indicates increased risk and it predicts the progression to severe preeclampsia. Now this S-split1 is a protein that blocks the growth factor and it is crucial for the blood vessel development. PLGF is also a protein that promotes new blood vessel growth and it is vital for placental health. Now what happens in preeclampsia is S-split1 level rises while the PLGF level falls. So this creates an imbalance and the ratio increases. So higher ratio indicating more severe placental dysfunction and higher risk for preeclampsia. Glycosylated fibronectin is a promising biomarker in predicting the preeclampsia. In the first trimester, that is in a window of 11 to 13 weeks, screening gives good idea, and the accuracy can be assessed by the range that we are seeing. If the test falls in a range of 50 to 250 microgram per ml, it is considered as abnormal, but then the severity is not that. It's mildly severe. If the range goes to 351 to 600, the positive predictive value is around 98%. The test is considered positive and with moderate severity. If the value is more than 601 microgram per ml, it is highly positive and it's a severe preeclampsia that we should be encountering. Now, those factors which reduce biomarkers. So first one is placental growth factor. It's a glycosylated dimeric glycoprotein. PLGF is synthesized in villus and extravillus cytotrophoblast, and it has got both vascogenic as well as angiogenic function. It is secreted by trophoblast cells and is a part of angiogenic vascular endothelial growth factor family. It binds to VEGF receptor 1 and thus increases during the pregnancy. So its decrease is abnormal. Now, if you see the triage of PLGF test, when the value is less than 12 picogram per ml, the test is highly abnormal and we are going to get severe placental dysfunction with a high risk for preterm delivery and severe preeclampsia. While the value, if it is more than 12 picogram per ml, the test is still positive and abnormal, but the severity will be less than the previous one. If the value is more than 100 picogram per ml, then the test is considered normal. So the possibility of delivering within 2 weeks is very, very minimal, and same is the development of preeclampsia. Now, placental associated plasma protein A, it has got, pregnancy associated plasma protein A. Its level of this in the first trimester is also having a predictive value for HDP development. Low PAPA suggests abnormal placental development, and value less than 0.6 multiples of median indicates higher risk with sensitivity of around 66% and a specificity of around 80%. But when this test is combined with uterine artery Doppler, it again improves the accuracy of detection. Alone, if this test is not a very good predictor. Vascular endothelial growth factor. If you see the pathophysiology of preeclampsia, it involves the shift from a pro-angiogenic to an anti-angiogenic factor. Primarily SFET1, which reduces the available VEGF and PLGF, and thus it causes a widespread vascular damage. So this imbalance leads to endothelial dysfunction, hypertension, and ultimately proteinuria. There are certain scoring systems also, and they are good predictors in the HDP profile. So one among them is the gestosis score, and the second is first trimester screening, that is a triple test, which is endorsed by Fetal Medicine Foundation. Now, word about gestosis score. If you see here, the score 1, that has been given if these are the points that has been picked up in a woman, like age older than 35, age younger than 19. We have already seen all these. When the obesity is present and BMI is more than 30. The score of 2 is given when the moderate risk factors are present, like family history of preeclampsia, GDM, multiple pregnancy, and a score of 3 is been assigned when the severe risk factors are present. So on the basis of this HDP score is also a valuable and efficient tool in predicting the preeclampsia. A score of more than 3 demonstrates optimum sensitivity and specificity. With a very less average assessment time of 5 minutes, it's a good tool for low resource settings. The simple ASHA worker and ANM worker can also perform this test. It is simple enough to be used by minimum trained staff, that I have already said. And the scenarios like India, where affordability, accessibility is a challenge, this can be utilized as a good predictive marker. Now, FMF triple test, it's a test where the maternal history is combined with the mean arterial pressure, uterine artery PI, and placental growth factor. This test is assigned in between 11 to 14 weeks, and it has got a detection rate of around 90% and the prediction rate of around 75%. Now, I want to draw the attention on this slide. I'm sorry. This is a very important slide. Now, if you see from here to here, all tests are single tests, which we have already seen. And the detection rate of early onset preeclampsia is in a range of around 60%. If you see here, the late onset, that is preterm preeclampsia, is around in a range of around 50%. And the term preeclampsia is around in a range of 40%. If you combine two of the tests, when the combo is used, the detection rate shoots by 80 to 90%. Here it is around 60-70%, and here it is around 50%. And if you see in the last, all the tests when they are given together, the detection rate of early onset preeclampsia is around 93 to 96%. And it is the preterm preeclampsia is around 70%, 80% almost. And here the term preeclampsia that you can detect around 50%. So such a good combination of tests are available. Now, evidence-based conclusion says that combination of these biomarkers along with the uterine artery Doppler provides the best predictive accuracy in identification of early onset preeclampsia. Early onset preeclampsia can be best picked up by combination of mean arterial pressure, uterine artery PI, PAPA, and PLGF. But if you want to have a more accuracy on late onset preeclampsia, then a split 1 to PLGF ratio will be a better predictive test. A word about preventive therapies now. The best time is a preconceptional counseling when you can put this preventive therapy on work. So identifying of high risk factor, this window should be utilized best for identification of high risk factor like obesity, sedentary lifestyle, previous medical disorders like diabetes, hypertension, or hypothyroidism. What happens when these women, they come to us and for the first time we give them the test in their first trimester. At that time, they come to know that they're already hypothyroid or they're already having diabetes. So at that time, as she is already pregnant, there is much in our hand, not much in our hand. And if she is not in a controlled range, then it becomes a very difficult problem for prevention. So this window should be utilized to correct their disorder prior to becoming pregnant. One more important thing in this window that we can do is a record collection of the previous pregnancy, because that gives a very big insight about her previous medical obstetric history, what she has been, to what range her blood pressure was, and what was the complications through which she has come now. Second important thing that we can do in this window is a modification of these risk factors. Because if you correct them and then she becomes pregnant, the scenario will be totally different. So you have to advise them healthy diet, should give emphasis on high intake of fruits, vegetables, proteins, high fiber diet, lots of water, and they should restrict on saturated fats and processed foods. Weight management again is very important. Generally, the concept is that when she's pregnant, she should gain the weight. Whatever is her basic weight doesn't have a issue. Even if she is obese, she should gain weight during her pregnancy. So that should not be the concept that we have to teach them. And we should make them to come to certain basic reduction, because after pregnancy, it will be very difficult for exercise counseling and the women also going for exercise. So let them reduce first and then they should become pregnant. Lifestyle modification plays a very important role. The aim should be at least 150 plus minute exercise to be advised for a week. Avoid smoking and alcohol, and stress management should also be done. Now, supplements and medications. There is insufficient evidence for certain things that we should understand, that like low molecular weight heparin. Just for prevention of HDP, we cannot start low molecular weight heparin. There should be certain definite indications for it. Multivitamins, zinc, magnesium, the market is flooded with all this, vitamin C, vitamin E, antioxidants. Even the salt restriction comes on paper, bed rest. The studies have shown that they do not have any role in prevention of HDP. The only thing is that they are heavy to the pocket of the woman, and the important thing which the patient has to take is being missed if they are taking these drugs. Calcium do play an important role. More than 1 gram per day is suggested. Tablet aspirin 150 milligram daily to be started in a window of 11 to 14 weeks up to 36 weeks is a test drug. There are multiple trials and studies which have been performed on aspirin, and such a wonderful drug that it is controlling the disease to a very high extent if it has been given in a proper time and proper dose. So this was a landmark trial, aspirin trial, which is done in 2017, which has involved 1,776 high-risk women. And the inference was that it has reduced the early onset preeclampsia, that is delivery before 34 weeks, by around 82%. And it has reduced the incidence of preterm preeclampsia, that is delivery before 37 weeks, by 62%. This is another wonderful trial, that is an aspirin trial of 2020. This was a large multinational randomized double-blind placebo-controlled trial where 11,000 women were the participants. They were all nulliparous and they have been given a aspirin in a dose of 81 milligram daily. And the dose was initiated in between 6 to 13 weeks. As the dose was low, see the difference. It has not reduced overall rate of HDP, but it has significantly delayed the onset by reducing the preterm HDP before 34 and 37 weeks. And it has also reduced the perinatal mortality. This is one more trial which is done in South Africa in 2020. And they found that 162 milligram daily aspirin, when it is initiated between 12 and 20 weeks, it reduces the incidence of HDP 6.2 versus 25.2, and early onset preeclampsia 2.4% versus 14% in compared to standard care, and representing around 75% reduction in HDP risk. The meta-analysis, which is done on a low-dose aspirin, that is 75 to 81, that has showed a daily aspirin in this dose, when started before 16 weeks, still reduces the overall risk of preeclampsia, but up to 30%. EVER trial, this is an ongoing trial which is still running, and it is comparing the dose of 75 milligram to 150 milligram per day. And here they are determining the optimum dose for preterm preeclampsia prevention in a high-risk woman. Another trial is also going on where they are comparing the dose of 81 milligram versus 162 milligram aspirin. So what is the key recommendation for primary prevention by aspirin that one has to remember? That dose of 150 to 150 milligram is considered more effective than 75 to 81 milligram. So we should prescribe in this range, not low dose. Then timing, initially it should be before 16, initiation should be before 16 weeks of gestation, but the ideal time is 11 to 14 weeks. That is before first wave of invasion. The duration continues until delivery or 36 weeks. The targeted population is high-risk women for HDP that we are detecting by our predictive test. Safety and compliance. It is safe in pregnancy, no increase in congenital malformation. The dose of 100 milligram though minimize the bleeding problem on risk, but 150 milligram is the one dose which is needed in high risk cases. Compliance, if it is more than 90%, the benefit will be better. Now a drug that is statin. Prastatin was the drug which is in a dose of 10 milligram per day to be started before 12 weeks of after 12 weeks of gestation, but before 20 weeks, is the one which is an emerging promise. Now, how these drugs are controlling the HDP, let us have an insight on this, because this is something which is very promising kind of medicine that is coming out. Endothelial and vascular protection is being provided by statins. They enhance the production of nitric oxide and they suppress the endothelin 1, which is a potent vasoconstriction. Hence, they reduce the oxidative stress. It is also maintaining the angiogenic balance restoration. We have seen that SFLT1 was increasing and PLGF was reducing in preeclampsia. This drug do the wonder by just doing the opposite of it. It decreases the anti-angiogenic factor, that is SFLT1, and it increases pro-angiogenic factor, that is PLGF, which are critical in the pathogenesis of preeclampsia. It also have an anti-inflammatory action by reducing the interleukin-6 and tumor necrosing factor alpha. If you see the clinical evidence and safety of statins, they have reduced the risk. Different meta-analysis on pravastatin have shown that the incidence of preeclampsia has reduced to 50 to 60%. And they have shown improved outcome in babies by increasing their birth weight, by reducing the NICU admissions and incidence of preterm deliveries. The safety profile is only pilot studies are available. There is no large scale randomized trial still. But what the pilot study shows is that there is no significant increase in congenital anomalies, neither any adverse neurodevelopment in the babies. The limitation and current status of this drug is that it is not currently a part of standard clinical guidelines for prevention of HDP, but they are recognized as a promising targeted therapy for high-risk patients in reducing preeclampsia, which is associated with morbidity. FDA in July 2021 removed the formal contraindication of statin use in pregnancy when the women were high risk for the cardiovascular disease. So still a long way to go for these drugs, but they are definitely showing the promising results on those patients who are either showing severe preeclampsia in their previous pregnancies and they're not having the live issues. So they can be good candidates who can be benefited from this, but still large randomized trials are needed before we can put the safety of this drug. Thank you very much for patience listening. I think I have done justice with the topic of prevention and prediction. Hello.
Yes.
Hello.
Thank you, madam. Thank you for
Yeah.
the wonderful talk. And
Thank you.
you have very well simplified the methods and the concepts of prediction as well as prevention of PIH. Not only that, you have also covered the HDP score and the recent updates regarding the aspirin as well. So I hope we are clear with your concepts as well. Anyone else wants to ask any question or any comments, they are most welcome. So, like, overall, it was a wonderful, fantastic document.
Thank you, ma'am. Thank you.
Thank you.
Thank you, Dr. Nitika, for the wonderful talk on prediction and prevention of pregnancy-induced hypertension. And thank you, chairpersons, for taking up this session. Welcome everyone to the second session of the same series, where we move on from prediction and prevention to now management of the real problem. To chair the session, we have three eminent chairpersons. We begin with Dr. Suhasini Bhopi. Madam, she is the president of Pusat Obs and Gynae Society 2025-26 and the director of Varad Netralaya and Maternity Home, Pusat District, Yavatmal. She's in private practice since the last 20 years. So we have a very senior gynecologist for this chairing this session with great inputs after the session. The next chairperson of this session, Dr. Sheetal Bhandari, ma'am. She's been the former president of Pusat Obs and Gynae Society 24-25, that is means the immediate past president. And with 20 years of experience as a practicing obs and gynae and the director of Devashish Bhandari Hospital, Pusat, she's committed to ethical practices and women-centered care. So we have another eminent chairperson here. The third chairperson in the same series is Dr. Dr. Arun Ratanlal Rathi. He has international trainings in advanced gynae endoscopy from France, advanced urogynae surgery from UK, diploma in ultrasound iron donor from Geneva in 2013. At the present, he's the director of Siddhi Vinayak Hospital and Test Tube Baby Center in Akola, and he's held multiple posts as both past president of Akola Obs Gynae Society 2014 to 15, past IEG executive member in 2004 to 2006, Vice President ISOPAP Vidarbha chapter 2019 to 21, and also the regional coordinator at Maharashtra chapter of ISAR, held at Nagpur on 19th to 20th July 2014, with many special achievements as the first prize in Foxy President's Rotating Trophy for the best activities for the year 2014-15 held at Agra, and the MMC Observer for CME on live endoscopy surgical demonstrations at Aurangabad, the National Conference at 2011, Navi Mumbai at 2014, and a masterclass in infertility in 2015. I request Dr. Suhasini Bhopi, madam, to please introduce the speaker for today's talk on management of hypertension. Dr. Suhasini, ma'am, please unmute yourself.
Thank you. First of all, thank you, Dr. MC Patel sir and Dr. Monica and Nivedita ma'am for this opportunity. Can I get the CV? Dr. Monali Sukesh Dole, she is director of Dole Hospital, consultant obstetrician gynecologist and ART consultant. She has done MBBS, DGO and FMAS and fellowship in reproductive medicine and LLB. In her medical career, she is trained in ART under Padma Shri Kamini Rao ma'am, advanced course in laparoscopic surgery under Dr. P.G. Paul at Cochin, ultrasonography and color Doppler training under Dr. P.K. Shah, worked at District Women's Hospital as a medical officer for 3 years, member of Society of Fetal Medicine, member of Indian Association of Gynecological Endoscopists, member of Association of Minimal Access Surgeries of India. Various social activities. She is founder, president of Rotary Ambika, secretary Amravati OBGY Society, executive member of Disha, which works for needful girls and women. She is member of Samajik Mahila Suraksha Samiti by Maharashtra Police Department. I request Monali ma'am to start the topic.
Dr. Monali, please unmute yourself.
Ma'am, just a minute. Just a minute.
Ma'am, you've joined with two devices, so you'll have to switch off one.
Am I audible now, ma'am?
Yes, ma'am. Absolutely. You're audible.
Yes, thank
Could you please share your slides?
Yes. Is it okay if I don't share my presentation and just read it out, ma'am?
Monali, do you want me to send the slides to the team so that they can share
Yeah,
it from their end?
please send it to them. Please send it to them.
Yeah, I'll just send. Wait.
In the meantime, we have Dr. Arun Rathi, sir, also is the chairperson. Sir, would you like to speak a few words on this topic, sir? Till Dr. Monali's presentation comes on screen. Dr. Arun, sir?
Hello.
Yeah. Yes, sir, you're audible.
Yeah, am I audible? Yeah. One
Yes.
second. I mean, I'm very sorry. I'm down
I know
with
you've got a,
yeah,
got a very
bad,
bad throat. You've got very bad throat.
Yeah. I'm thankful to Dr. MC Patel, sir. He's been a teacher figure and has always guided and inspiration to all of us, not only academically, but as a human being and serving the Foxy. So I always wish him all the best. And regarding this topic, this is one of the basic topics where the expertise, different consultants are going to have different views, and with their clinical knowledge, we would be able to fetch good practical tips for the future.
Thank you, Arun, sir, for your words of wisdom. And Dr. Monali, I think your slides are on the screen now.
Yes, ma'am.
Yeah, thank you.
Let me go out from another system. Yeah. Yes, very good evening. I'm so sorry for a little glitch. I was just busy with something. So let us start with the presentation. Let us talk on the hypertensive disorders in pregnancy, the evidence-based management and Indian perspectives. Will somebody change the slides for me? Yeah. What is the burden of hypertensive disorders in pregnancy? If you look at the Indian scenario in India, the hypertensive disorders complicates 7 to 10% of all pregnancies and account for approximately 8 to 10% of the maternal deaths. The maternal mortality ratio, that is MMR in India, stands at 103 per 1 lakh live births, with significant contributors from the HDP. The burden is disproportionately higher in rural areas, tribal populations, and lower socioeconomic groups where access to antenatal care and timely emergency obstetric services remains limited. Next one. If you come to the classification of it, it goes into the preeclampsia cases, eclampsia, chronic hypertension, and the gestational hypertension cases. How you classify the cases? The gestational hypertension cases, we call them as the cases that occurs in 6 to 7% of the pregnancies and may progress to preeclampsia in 15 to 20% of the cases, requires close monitoring. If we go into preeclampsia cases, these are the new onset hypertensive disorders after 20 weeks of pregnancy with proteinuria that is up to more than 300 milligram in 24 hours or evidence of maternal organ dysfunction. This is a multi-system disorder with potential for severe complications. It affects almost 2 to 8% of the pregnancies with early onset. It has worse outcome, that is less than 34 weeks, and can present without proteinuria if severe futures present. If we go to eclampsia, this is the occurrence of new onset gestational tonic-clonic seizures in a woman with preeclampsia that cannot be attributed to other causes. It represents a critical obstetric emergency. It complicates around 1 to 2% of the preeclampsia cases, can occur antepartum, intrapartum, or postpartum, and the maternal mortality rate is almost 1 to 2%. If we want to classify the chronic hypertension present before pregnancy or diagnosed before 20 weeks of pregnancy, it persists beyond 12 weeks postpartum and requires different management considerations. The prevalence is almost 1 to 5% of the pregnancies, an increased rate of superimposed preeclampsia in 25% of the cases, higher rates of placental abruption and fetal growth restriction. Next slide, please. Next slide. If we go to the pathophysiology, the understanding the multisystem disease process, it is all the time it is an enigma. The preeclampsia cases is fundamentally a disorder of placentation with widespread maternal endothelial dysfunction. The pathophysiology involves a two-stage process that begins early in pregnancy. The stage 1 is the abnormal placentation and stage 2 is the maternal syndrome that all of us know. And in this syndrome, the main things are the cardiovascular effects, neurological complications, renal manifestations, hematological changes, and hepatic involvement. Next one, please. What are the risk factors and screening? The high-risk population in Indian context, the high-risk population patients are with the obstetric history of previous preeclampsia or eclampsia, the first pregnancy, the multiple pregnancy, that is twins or triplets, the molar pregnancy, the new paternity, and the interpregnancy interval of more than 10 years. What are the pre-existing medical conditions can be there? They can be chronic hypertension, diabetic mellitus cases, the chronic kidney diseases, the autoimmune disorders, that is SLE and APL positive APLA syndrome, the thrombophilia cases. What is the demographic factors? The age extreme, that is less than 20 years or more than 35 years. The obesity, where the BMI is more than 30 kg per meter square. The family history of preeclampsia, the low socioeconomic status, and inadequate antenatal care. Next slide, please. What are the diagnostic criteria? The diagnostic criteria according to these guidelines is the blood pressure criteria, that is hypertension, systolic hypertension more than 140 or diastolic more than 90 on 2 occasions at least 4 hours apart. What is severe hypertension? A systolic BP more than 160 or diastolic more than 110, which should be confirmed within minutes to facilitate timely antihypertensive treatment. The blood pressure should be measured with appropriate technique, patient seated, arm at heart level, using correctly sized cuff after 5 minutes of the rest. And how will be the proteinuria assessment will be done? The proteinuria assessment, the significant proteinuria is defined as more than 300 milligram per 24 hours urine collection, or proteinuria or creatinine ratio is more than 0.3 milligram per deciliter, or the dipstick reading of 2 plus used only if other quantitative measures are not available. In a 24-hour urine collection sample remains the gold standard, but spot urine proteinuria, creatinine ratio provides rapid assessment and a good correlation. Wherein there is a renal insufficiency, the severe creatinine more than 1.1 milligram per deciliter or doubling of the creatinine, absence of other renal diseases. When we talk about the hepatic dysfunction, the elevated transaminases more than 2 times upper limit of normal with or without right upper quadrant pain that patient typically complains about. The neurological features are new onset persistent headache, visual disturbances, altered mental stress, or stroke. In the hematological abnormalities, the thrombocytopenia or platelet count less than 1 lakh, or hemolysis and or DSC. In the pulmonary edema, clinical or radiological evidence of fluid accumulation in lungs. Next slide, please. The FIGO recommendation for the early detection and the prevention strategies is the FIGO recommends FIGO has released the comprehensive guideline in 2018 focusing on pre-pregnancy counseling, early screening, and evidence-based prevention strategies to reduce the burden of preeclampsia globally. This tells us the pre-pregnancy counseling and risk assessment identify the women with risk factors, optimize chronic conditions, achieve healthy BMI, and provide information about preeclampsia warning signs. Then there is early screening at 11 to 13 weeks. First trimester combined screening using maternal risk factors, mean artificial pressure, uterine artery Doppler, and biochemical mother, that is PIGF and PAPE, can identify 75 to 90% of the early onset preeclampsia cases. How about the low dose aspirin prophylaxis? For high risk women, initiate aspirin 75 to 150 mg daily from 12 to 16 weeks until 36 weeks of gestation. This reduces the preeclampsia risk by 50 to 80% in high risk population. What about the calcium supplementation? In populations with low dietary, low calcium intake, that is less than 600 mg per day, calcium supplementation of 1.5 to 2 gram daily reduces preeclampsia and maternal mortality, particularly relevant for India, wherein the calcium levels is usually low. How about the regular monitoring? Serial BP management, symptom assessment, and laboratory testing at scheduled interval for high-risk women throughout the pregnancy. What are the evidence-based intervention? They tells us about the aspirin. There is a strong recommendation for high-risk group. Calcium recommended for low intake populations. What is not recommended is vitamin E or C, fish oil, magnesium, garlic, folate for preeclampsia prevention. And how about the lifestyle? The moderate exercise, healthy diet, and avoid excessive weight gain. The Indian implementation challenges are, while FIGO recommendations are evidence-based, implementation in India faces barriers, including limited access to first trimester screening, loss of biomarkers, availability of low dose aspirin, and ensuring calcium supplementation in rural areas where dietary calcium is deficient. Next one. What is the first line management? The antihypertensive therapy and the maternal stabilization. The management of hypertensive disorders requires balanced approach controlling maternal blood pressure to prevent complications while maintaining the adequate uteroplacental perfusion. The goal is not normotension, but rather controlled hypertension. That is a very, very important thing. The treatment thresholds are the severe hypertension, wherein BP is more than 160 to 110, requires urgent treatment within 30 to 60 minutes to reduce risk of maternal stroke and other complications. In non-severe hypertensive cases, wherein BP blood pressure is 140, in the range of 140 to 159, 90 to 109 millimeter, treatment threshold depends on the presence of comorbidities, gestational age, and presence of preeclampsia features. Target blood pressure should be 130 to 150 systolic and 80 to 100 diastolic to balance the maternal safety with uteroplacental perfusion. And what are the first antihypertensive drugs? The first antihypertensive drugs are the labetalol. That is in acute cases 20 milligram IV bolus, then 40 to 80 milligram every 10 to 20 minutes, maximum to 300 milligram. And the maintenance is 100 to 400 milligram twice daily, maximum is 2400 milligram per day. This is contraindicated in asthma and heart block. How about the methyl dopa? 250 to 500 milligram, 2 to 3 times daily, maximum up to 3 gram per day. Safety in pregnancy with long track record, slow onset 4 to 6 hours, suitable for maintenance therapy. Nifedipine in acute cases 10 milligram, it is orally, repeat after 30 minutes if needed. Maintenance is 10 to 20 milligram orally 3 to 4 times daily, extended release 30 to 90 milligram once daily, fast onset, well tolerated. How about the hydralazine? IV bolus 5 milligram bolus, then 5 to 10 milligram every 20 to 40 minutes, maximum up to 20 milligram. Previously, it was a first line, but higher adverse effects uses if other unavailable or ineffective. Next, please. What are the critical care management and timing of delivery in severe preeclampsia cases? When we talk about the severe cases, severe preeclampsia cases requires intense monitoring, multidisciplinary care, and careful decision making regarding delivery timing. Maternal stabilization should preclude delivery. and the only definitive cure is delivery of the placenta. What is the initial assessment? Initial assessment is the admission to higher dependency unit, establish IV access, continuous BP monitoring, strict fluid balance, and fetal monitoring. About the maternal stabilization, control of blood pressure, initiate Maxel prophylaxis, strict fluid restriction up to 80 ml per hour, and monitor symptoms and reflexes. How about the laboratory investigations? Laboratory evaluation is is in the complete blood count, liver enzymes, renal functions, coagulation profile, LDH, peripheral smear if hemolysis is suspected. And what about delivery planning? Determine the delivery time based on gestational age, maternal condition, and the fetal status. Prepare for complications. What are the delivery timing guidelines? If the pregnancy is 37 weeks, deliver. If the delivery is recommended for all women with preeclampsia, regardless of severity, expected management beyond 37 weeks increases maternal risk without involving neonatal outcomes. How about the 34 to 37 weeks? Severe features like delivery recommended after maternal stabilization and corticosteroids for lung maturity. Without severe features, may consider expectant management with very close monitoring. If less than 34 weeks, most challenging scenario requires tertiary care facility with NICU. Consider expected management if maternal condition is stable and no urgent indicators for delivery. Corticosteroids for fetal lung maturity is essential. How about the delivery indicated for? When is indicated for is uncontrolled blood pressure, eclampsia, pulmonary edema, DIC, renal failure, placental abruption, non-reassuring fetal status, and HELP syndrome. What is the mode of delivery? The mode of delivery is vaginal delivery is preferred if obstetric conditions are favorable. The induction of labor with close monitoring of maternal fetal status. How about the cesarean section? These are the indications of cesarean section include standard obstetric indications plus maternal instability, failed induction or deteriorating maternal or fetal condition. Next slide, please. How about the magnesium sulfate protocol, the seizure prevention and the treatment guidelines? When we talk about the Maxelf, the Maxelf is a drug of choice for both prevention and treatment of the eclamptic seizures. It reduces the risk of eclampsia by 50 to 60% and is superior to phenytoin and diazepam. Understanding proper dosing, monitoring, and toxic management is essential. What is the Pritchard regimen? Is the IM route and the Zuspan regime, that is IV route. Most of the times we are using the Zuspan regime. The loading dose is 4 gram IV over 10 to 15 minutes and maintenance is 1 to 2 gram per hour IV infusion via pump. Duration is for 24 hours after delivery or last seizures. Preferred when IV infusion pump is available. It allows precise dose control and easy adjustment. What are the indications for Maxelf? The treatment of all cases of eclampsia, prophylaxis for severe preeclampsia with with any severe features, intrapartum during labor in women with preeclampsia, postpartum continue if given antenatally or intrapartum. What is the monitoring during Maxwell therapy? The monitoring is clinical monitoring, assess hourly respiratory rate. It should be more than 12 per minute. Urine output should be more than 25 ml per hour, and the patellar reflexes should be present. How about the therapeutic range? It should be serum max self levels 4 to 7 milliequivalent, not routinely measured in most Indian settings, rely on the clinical monitoring. And if I would like to go on the anesthetic consideration, safe delivery planning for hypertensive disorders, anesthetic management in women with hypertensive disorders requires careful planning, close monitoring, close communication between obstetrician and anesthetist, and the vigilance for potential complications. Regional anesthesia is generally preferred when feasible. What is a pre-anesthetic assessment? Review medical history, current medications, if any, especially Maxelf. Assess airway, check platelet count. It should be more than 75,000 for spinal anesthesia. Coagulation profile, if indicated. BP control status, discuss plan with the patient. How about the regional anesthesia? It is preferred. Epidural or combined spinal epidural for both vaginal delivery and cesarean section. Provides excellent analgesia, control BP, allows titration, reduces stress response, and contraindicated if platelets are less than 75,000 or coagulopathy is present. When the general anesthesia is required, it is reserved for urgent delivery when patient refusal for regional anesthesia or contraindications to regional. Higher risk of failed induction, aspiration, hypertensive disorders to laryngoscopy awareness requires careful BP control during induction. What are the special consideration when we are thinking about Maxelf interactions? It potentiates the muscle relaxants, so the dose should be reduced. It may prolong neuromuscular blockade and can cause maternal weakness. How about airway management? Higher risk of difficult intubation due to edema. Have experienced help available, equipment ready for field induction, and consider awake fiber optic intubation if severe airway edema. How about the fluid management? Avoid fluid overload, risk of pulmonary edema, especially with maximum target. Target should be 80 ml per hour maintenance and crystalloid preload before regional anesthesia, that is 50 to 1000 ml. It should not be bolus. Blood pressure control, avoid the sudden hypotension when regional techniques. Treat hypertension during laryngoscopy, that is labetalol and other drugs. Aim for gradual control of reduction of blood pressure. What is the anesthetic technique for cesarean section? Regional spinal is given if the platelet count is more than 75,000. Gradual closing to minimize hypertension. Left lateral tilt to avoid aortocaval compression. Vasopressor ready. When it should be ready preferred. Monitor BP every 2 to 3 minutes. Ephedrine should be ready. The general anesthesia, pre-oxygenation with 100% oxygen, rapid sequence induction, blunt hypertensive response, reduce muscle relaxant dose if Maxelf is given, maintain anesthesia with low volatile agents, and extubate fully awake to avoid the aspiration. Next slide, please. How about the postpartum management? The postpartum management monitoring and long-term cardiovascular risk management is the delivery of the placenta does not immediately resolve preeclampsia. The postpartum period remains high risk for complications, including eclampsia, stroke, pulmonary edema, and renal failure. Close monitoring for 40 to 72 hours essential, with 30% of eclampsia seizures occupying in the postpartum period. How about in the first 48 to 72 hours, that is immediate postpartum care? The monitoring is with the blood pressure every 4 hourly minimum, every 15 minutes if severe, strict fluid balance, assess for symptoms, any headache, visual changes, epigastric pain, monitor urine output, continue Maxil for 24 hours after delivery if given for severe preeclampsia, eclampsia cases, lab test, repeat CBC, liver enzymes and renal function at 24 to 48 hours or if clinically indicated. Antihypertensives, continue medications, may need dose adjustment. Target is blood pressure lower than 150 to 100. Most women require treatment for weeks to or months. How about the hospital discharge planning? Blood pressure control, ensure blood pressure stable before discharge, provide clear medication instructions, save drugs if breastfeeding, that is labetalol, nifedipine, methyl-dopa, avoid atenolol or ACE inhibitors. Warning sign indications, you should educate the patient about the warning sign, that is headache, visual disturbances, right upper quadrant pain, reduce urine output, chest pain and breathlessness. Follow up blood pressure check within 72 hours of discharge, then weekly until normalization, reduce medications gradually. How about the postnatal review? It is after 6 to 8 weeks, blood pressure should normalize by 12 weeks postpartum. If persistent, investigate for chronic hypertension. Proteinuria should resolve. If persistent, refer to nephrologist. Counseling about a future pregnancy should be done. Long-term cardiovascular complications and lifestyle modifications should be advised. What are the long-term cardiovascular risk assessment? Women with history of preeclampsia had 2 to 4-fold increased risk of future cardiovascular diseases, hypertension, stroke, and chronic liver disease. This risk is higher with early onset or recurrent preeclampsia. Screening recommendations, annual BP checks, assess for metabolic syndrome, screen for diabetes, lipid profile, maintain healthy lifestyle and lifestyle modifications, healthy diet, regular exercise, maintain healthy BMI and avoid the smoking and manage stress. Contraception counseling, all contraceptive methods can be used safely after preeclampsia, including combined hormonal contraceptives once blood pressure is controlled. Progesterone only pills are preferred if BP is elevated. Provide counseling about birth spacing at least 18 to 24 months and optimization before the next pregnancy. How about the future pregnancy planning? The pre-conception counseling, optimize the weight and blood pressure, start folic acid, assess for chronic hypertension and diabetes, low dose aspirin from 12 weeks, reassurance risk 15 to 20% overall higher if early onset preeclampsia, preterm delivery or adverse outcome in previous pregnancy. Next slide, please. Next slide, please. Now going into the Indian healthcare challenges and resource limitations and rural-urban disparities. Despite advances in understanding and management of hypertensive disorders in pregnancy, significant challenges persist in implementing evidence-based care across India's diverse healthcare landscapes. These barriers disproportionately affect outcome in rural and underserved populations. You all know we need to go to the rural places. We need to increase diagnostic limitations. We need to increase the workforce shortages should be taken care of. The socioeconomic barriers should be broken. The rural population, it is much more in rural population compared to urban one. So we need to reduce the rural urban divide. Next slide, please. How about the quality improvement initiatives? This Laksha program and the maternal death audits, the early detection, emergency preparedness, skill management, and early referrals, management at a higher referral center, hospital deliveries. These are the challenges, and we should try to achieve those. What are the key components? Key components will be the infrastructure upgrades in labor rooms, essential drugs and equipment availability, skilled birth attendants, prevention and management of complications, and respectful maternity care practices should be practiced. Next slide, please. The key takeaways, the implementing evidence-based protocols in Indian practice settings, the risk stratification and prevention. Indian high-risk women we should identify the high-risk women at first antenatal risk visit, initiate low-dose aspirin from 12 to 16 weeks for high-risk women, ensure calcium supplementation, then standardization of the diagnosis and classification into the specific groups, appropriate antihypertensive management should be started, universal access to management sulfate, magnesium sulfate should be done. Now with the IV Maxelf available left and right, we should promote it IV Maxelf in the rural settings. It should be made available at periphery. That early timely decision making and early referral in rural settings, clinical postpartum monitoring should be critical. Long-term follow-up and counseling and quality improvement and audit should be done. What is the take-home message? Evidence-based management of hypertensive disorders is feasible even in resource limited settings. Focus on early identification, appropriate use of Maxelf, judicious antihypertensive treatment, timely delivery, and vigilant postpartum care. Most maternal deaths from preeclampsia, eclampsia, and preventable with adherence to established protocols and ensuring availability of essential interventions. Next slide, please. Thank you for patient listening. Thank you so much.
I would request the chairpersons to please sum up this talk. Chairpersons, Dr. Rathi, Dr.
Thank you, Sangeeta.
Yeah.
Hello.
Yeah, Dr. Rathi, you're audible.
Yeah. Am I audible? Yeah.
Yeah, absolutely.
An excellent talk. Very like theoretically and knowledge-wise excellent. But the practical tips are it is each patient is individualized, and you need to take the call at the right time, judging all the parameters in line and go ahead. Multidisciplinary approach is something which is a demand of today. So always feel free to take the help of the other disciplines, because there are so many advancements which are happening at a great speed. So even though things which are not there, because we have read the textbooks, and the recent advances are happening so fast. So always having a colleague of another discipline with a specialty knowledge is always helpful to have a better outcome for the patient management. Thank you.
Thank you for those tips on practical management of HTP. I would now hand over the session to the third coordinator.
Thank you, chairpersons and respected speakers. I request Dr. Shatabdi to please take over for the third session. Okay. I think she is not yet joined. So can I introduce our chairpersons for the next session, Dr. Alka Kute Madam, Dr. Girish Mane, Dr. Paresh Gandeja Sir, and Dr. Poonam Belkar Madam, who will be chairing an important session by none other than Dr. MC Patel Sir on the legal issues in high-risk pregnancies. Can we have the CV slides, please? Dr. Alka Kutte Madam is currently the chairperson of the MTP committee, FOXY, She holds an LLM in criminology and a postgraduate diploma in human rights. She's also the national past president of the BPNI Maharashtra state and currently is a legal advisor at BPNI. She's also founder, member, and national secretary. Founder and the National Secretary of Human Milk Banking Association of India. She is the master trainer for the Foxy Dhira and a regional trainer for Foxy IIP Perinatal Meet. We welcome you, ma'am, as a chairperson. The next slide, please. Dr. Girish Mani, sir, is the past chairperson of the Adolescent Health Committee of Foxy as well as AMOX in the last 2 terms. He is also the winner of the Dr. Meru Hansotia Best Committee chairperson of the Foxy of 2019 to 22. As also awarded at AMOX, the winner of the Foxy Talent Singing Contest. He has been awarded by the Governor of Maharashtra in Raj Bhavan for exemplary work done during COVID pandemic. Recipient of the Durusha Youth Trophy, Dr. Sadhna Desai Award, and he's contributed more than 7 chapters in Foxy Focus. We welcome you, sir, as a chairperson. The next slide, please. Dr. Paresh Khandicha, sir, is a consultant to OBGYN and IVF specialist at the past president at Yavatmal. He's also on the PCPNDT District Advisory Board. We welcome you, sir. The next slide, please. Dr. Poonam Purkar, madam, is consultant at Amravati. Currently, she serves as the president of the Amravati OBGYN Society. She is also the organizing chairperson of the AMOX Zonal Conference, which was held in 2025. She has also won the Dr. D.K. Trank Reproductive Healthcare Promotion Trophy for the Amravati OBGYN Society. We welcome our chairpersons and request them to please introduce our speaker, none other than Dr. M.C. Patel, sir. Is any of the chairperson around? I think I will introduce her so that we don't waste more time. Can we have the next slide, please? Sir is the author of Foxy Uniform Consents. He is a medical legal trainer and support system for majority of the Foxy members. Sir has been the past vice president of Foxy in 2018, the chairperson of the Ethics and Medical Legal Committee of Foxy in 2011 to 13, the organizing secretary of AICOG 2017, the honorary secretary of this SOGOG Gujarat from 22 to 25, the organizing chairperson of the MMCon in 2018, and he is also the current honorary member of Foxy PNDT, the Violence Against Doctor and Regulatory Cell. He also has government and statutory roles, including the PDT NMIC Government of India 2015, the Gujarat PNDT Supervisory Board, the National Managing Body of the Indian Red Cross. He has distinguished community service since the last 23 years under the Dhanvantri Seva Yatra under NMO and Seva Bharati, which have been organized in the Northeast states. Services include medical camps in Jammu and Kashmir also, and he's been the president of the Lions Club at Gadodla. He has professional leadership, including the president of the Ahmedabad OBGYN Society, IMA Ahmedabad, the national president of NMO, and the organizing chairperson of the Vivekanand NMO Con. We welcome you, sir, to deliver a very important talk on medical legal aspects of high-risk pregnancy.
Thank you, Monica, for kind words. Let me share my screen. May please be allowed. Yes. Is it seen full screen?
Yes, sir, it is seen.
Full screen?
Yes, sir.
Yes, fine. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the society's president and secretary who have joined this webinar and all the delegates who have joined this webinar, of course, all the faculties and guests also. At the same time, I would like to thank you all. During my election campaign last time, you all stood with me just like a rock. Though I lost, but I believe in this. This is rightly written by Shraddhe Atal Bihari Vajpayee. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end but new beginning, and journey to Sub Foxy continued with renewed patience. So my commitment still continued. Wherever you are, I'll be there. Promise to reach the unreached and seeking your blessings for the same post, President Foxy, this year in election year 2026. So today we are going to discuss legal issues in high-risk pregnancy. Is it worth discussing? Yes. If it is yes, then why? Because medical litigations are increasing in number, and unluckily, we gynecologists rank first. Because in our day-to-day practice, we take utmost care of any of our patient in obstetric, but accident may happen, and once it happens, it becomes a potential area as far as medical legal consequences are concerned. And we have to save mother, we have to save baby, and at the same time, we have to save our own care, and that is our obstetric practice. And we are just like this innocent bird, always at danger of cobra of law. So let us see few of the cases which are decided in different courts. Book patient, pregnancy after 15 years of active marriage life, conceived with ART, regular antenatal checkup, USG every
Sir,
time.
excuse me, sir, your slides are not moving, sir.
In my computer, it is moving. Again, the same problem last time also this happened. Anyway, I will go
Now
like
it is
this.
visible, sir.
Anyway, but this is not full screen, na?
This is not full screen. Yes.
No issue. This way I will go. So it was book patient, pregnancy after 15 years of active marriage life, conceived after ART, regular antenatal checkup, USG every time, and say normal except polyhydramnios. At 36 weeks of pregnancy, it was found to be a intrauterine fetal death on routine antenatal checkup. Cesarean section was advised, routine preoperative investigation were done, and blood sugar was 432. So case was filed, compensation demanded 2 crores. So where thing went wrong? Because as such, this case is yet to be decided, still is it pending. But there are so many situations like this. And in this type of situation, can you relate to this type of situation? Let us see. Forgot blood grouping and later on found it to be RH negative. Forgot to do knuckle translucency, double marker, triple marker, and NIPT, and baby had a Down syndrome. Forgot to do GDM screening, and patient found to have complications later on. Forgot to ask for history of allergy to some drugs, and patient ended into allergic reaction to some drug. RH negative, and you forgot antenatal NTD. Low AFI and you took no action. Blood pressure 140 by 100 mm of Hg, urine albumin 1 plus, and you took no action. Pre-eclamptic patient complain of headache, you prescribed simple crocin and she threw a fit. Severe pre-eclamptic patient in labor, liver enzymes not done, and HELP syndrome missed. Phone from patient on Sunday evening that there is reduced fetal movement. You said, show me next day morning, and she came with IUFD. So and so on. So this type of the situation we face in our day-to-day practice. So reason one for litigation is dissatisfaction on part of patient and relative, where we forgot to screen for high risk factors. and neglecting a symptom or positive report as far as screening is concerned. So will it be considered error of judgment or negligence? So when you know that this may prove dangerous for patient, it cannot be considered as a error of judgment. It is a case of negligence. Say for example, when it is a case of preeclampsia, and if she complains headache, and we simply go with a tablet paracetamol, it won't work as far as medical legal problems are concerned. So how do we tackle all this, our enjoyment? Not to forget to screen for certain investigation. So pregnancy profile to be handed over to the patient on first visit. What is pregnancy? Which are the further investigation we are going to do? What is its implication? And she may get it signed on second visit. So it shows your consent that you had explained everything to the patient in language which patient can understand. Follow guidelines for screening and ensure that you will not miss any high risk factor. Let us see one more case. In this very case, there was fever between 30 to 34 weeks of pregnancy. Torch was not done. IUGR baby delivered prematurely at 36 weeks. Later on, she ended into cerebral palsy. So, inference held by the court in this particular case, there was no negligence on part of doctor, because court had a inference that torch is not a routine screening test, and which is mentioned in Foxy guideline. So she put reference of that Foxy guideline that torch is not routine screening test. So court had considered that argument. It is indicated for fever in first trimester. Cerebral palsy cannot be diagnosed antenatal, and in this case was filed against in favor of doctor. So in this type of situation, carry home message is follow guidelines and protocols for screening and management of GDM, Rh negative patient, twins, severe preeclampsia, and if needed, crash LSCS. So if we can manage all these patients as per standard guideline, then case could be in our favor if at all we are facing any litigation in court of law. Let us see one more case. It was unbooked patient, primary 34 weeks of pregnancy, PIH. It was very first visit with this gynecologist, advised necessary investigation and treatment. Very next day, she she developed abruptio placentae and IUFD. Cesarean section was advised, but relative opted option to go for second opinion. They went to surgeon in nearby town. CS was advised. CS was done, but again she ended into atonic PPH and hysterectomy was done and case was filed, notice was served. Allegation for first gynecologist was not properly managed to prevent abruptio placentae, and to surgeon not tried to prevent PPH, and atonic PPH was not managed properly. So these are the some allegations in this type of situation. Of course, I was a medical legal counsel for both of them in this particular case. So for first gynecologist, allegation was not properly managed to prevent abruptio placentae. It was very first visit with this gynecologist. He investigated, he prescribed all necessary treatment, he diagnosed case as a PIH. So there was no negligence on part of gynecologist who we could convince court, and gynecologist was out of problem. As far as surgeon is concerned, allegation was not tried to prevent PPH, and atonic PPH was not managed properly. So in this particular case, when she ended into atonic PPH, surgeon gave oxytocin, ergometrin, carboprost, 2 units of PCV, stepwise devascularization, and compressive suture, because gynecologist was assisting him, surgeon was doing cesarean section. And in all this situation, in spite of all these efforts, bleeding was not getting controlled. So uterus was removed. So my argument in the court was, we have not removed uterus, but we have sacrificed uterus to save life of patient. So when there is a question of life and death, then we have to balance and we have to see whether life is important or uterus is important. And court was convinced and case was decided in favor of that surgeon also. Let us see one more case. It is real happen case in city of Ahmedabad only. It was case for cesarean section. Patient was Rh negative and during cesarean section there was bilateral uterine artery tear. So blood was not ready, cross match was not done, and patient was shifted to Municipal Medical College Hospital, and on the way patient expired and notice was served. As such, in this particular case, patient had been to gynecologist 4 days prior. She was advised plan cesarean section with all preparation of blood because she was Rh negative. But patient absconded from the hospital. She didn't turn up to get admitted. But in an emergency after 4 days, at middle of night, she had been to hospital. It was acute emergency. Cesarean was to be done. She sent blood for cross matching in nearby blood bank, but it was little late and ultimately all this happened. So in this particular case, allegation on part of relative was not anticipated complication procedure and she was not ready to go with intensive care. And as far as inference held by the court was, in PM examination, it was mentioned that it was intra-abdominal hemorrhage following negligent surgical procedure. As such, can a person doing cesarean section comment about surgical procedure? It was negligent surgical procedure. One more area was there for discussion, and one more inference held by the court was no blood kept ready and medical record not to be believed, because in this particular case, in operative note of gynecology, she wrote that vitals were within normal limit, and in anesthesiologist note, it was mentioned that vitals were compromised. So there was contradiction in note of gynecologist and anesthesiologist. So this note were not taken into consideration by court, and case was decided in favor of relative of patient, and a compensation of worth rupees 2.35 lakhs was awarded in favor of relative of patient. So number two reason for litigation is not cross-matching blood during high-risk delivery cases. So in particular case, when you are dealing with a case of RS negative, it is always advisable to send sample in nearby blood bank and keep 2 units at least PCV ready in that very blood bank. If it is not required, fine, we will not demand. But if it is ready, it shows your consent in court of law that you have taken all the measures to save life of patient if at all any emergency happens. And consent for blood transfusion is to be taken separately if blood transfusion is planned. And proper record keeping is very much must. And there should not be any contradiction whenever you have involved more than one specialist in that very management of that very patient. Then we should go with all the notes and we should see that there is no contradiction in the note of other specialists. Let us see one more case. Again, it was Rh negative patient. Indirect cum test and NTD at 32 weeks were given. Atonic PPS during LSCS. Subtotal hysterectomy was done, and death at tertiary care hospital in this particular case. So at National Commission has mentioned that there is no negligence in management on part of doctor because he had given when patient was Rh negative, he went with indirect cum test. At 32 weeks, he gave NTD, but atonic PPH during LSCH, which is not predictable many a times, and ultimately, with in spite of all the efforts, he couldn't control bleeding. He went with subtotal hysterectomy, but ultimately, patient was expired. But there was inference held by the court was that blood should have been arranged, or patient should have been referred to higher center. So in this type of situation, when patient is Rh negative, we should be very clear in this situation, and we have to be ready with blood in nearby blood bank. Our observation is that in 80% of medical legal cases against gynecologists, they are obstetric related cases, and 80% of these cases are related to cesarean section complication, and 80% of complications are related to hemorrhage. So it is very obvious that if one wants to be 80% free of litigation, take care of bleeding and cross-match blood, and be ready and available with blood transfusion if at all it is needed. This is also our observation. Many of us as a habit to send a cross match for every patient in labor whenever they are admitted in their hospital in nearby blood bank. So it proves your caution, and it becomes a good defense in your favor if at all you are facing any litigation. Let us see few of the situation we face in our practice. No intercourse in a case of placenta previa, you had advised, but patient turned hostile. You never told, you never advised. So this type of situation may occur. Counsel for IUGR patient about involved risk, and again she told that you never told. You had told that in diabetic mellitus, sudden IUFD is known and it is possible, but she again became hostile. You never told. So these are the some situation. You said that everything is okay, but husband says now suddenly how come she died of amniotic fluid embolism? So these are some situation. Many times we advise them accordingly, but in court of law, patient may go hostile. So these are the challenges in our counseling also. Of course, many times OPD is too busy. We have no time to counsel patient in detail. Many times our gynecologist will say like this, I am not trained to communicate properly. Client these days are well informed and too smart. And in spite of telling everything, patient may later say that it was not told. So in this type of situation, reason 3 for litigation is lack of counseling and proper consent. So in this situation, it is not just enough to communicate. You should be able to prove it in court of law that you did it. You had communicated, you had properly counseled patient, you have properly explained everything about the management part, and with all the probable complication, etc. Let us see one more case. Again, it was case of pregnancy with mitral stenosis and mitral incompetence. Seen by physician, cardiologist was not involved, MTP was not advised. At 8 months, she went into failure, and physician advised LSCS, post-operative death in ICU within 4 hours after cesarean section. So in this case, National Commission had an inference that cardiologist was not involved, physician was involved, and in later had mentioned physician and cardiologist is misrepresentation, and MTP was not advised if at all it was needed, and no surgical intervention advised in second trimester. So epidural anesthesia or spinal anesthesia should have been preferred in case of CCF. These are the inference held by the National Commission in this particular case. And compensation of rupees 7.8 lakhs was awarded in this particular case. And stricture was also passed. Many labs, radiology units are run by unqualified doctor. Let us see same type of one more case. Antenatal records of visit in 9th month shows tachycardia and breathlessness, no physician reference. Patient died 4 days after delivery due to cardiomyopathy. Let us see one more case. Antenatal visits uneventful, LSCS uneventful. 8th day post-operative, patient was in ICU for some sudden problem and diagnosed as a tight mitral stenosis. So in this type of situation, reason 4 for litigation is I am the only consultant approach. So in this type of situation, carry home message is respiratory and cardiovascular system evaluation in each and every obstetric case is very much mandatory. Many of our friends have no habit to put stethoscope on chest, and it may end into this type of problem just we discussed prior. Take references of super specialists as early as possible whenever it is needed. And multi-speciality approach is always better and in favor of not only in patient but in favor of doctor also. One more important question many a time asked, where should we manage high risk pregnancy cases? As such, there is no guideline. But whenever this type of cases are in court of law, court consider certain things and they ask yourself arrangement of blood. Wherever you are dealing with patient, are you able to arrange blood from your hospital or from nearby blood bank or so? Arrangement of consultant, can you arrange consultant within no time? Facilities for emergency investigation, facility for crash LSCS, neonatal backup, and multidisciplinary approach. Whenever more than one consultant is needed, can you arrange for that? If you can answer all those questions, you can manage patient at any place. Let us say this area also, terminally ill patient on ventilator. Many times we face this type of situation. Terminally ill patient on ventilator and vasopressor support, and relative may say we cannot afford anymore, and intensivist will say now it has become hopeless case and there is no hope. In this situation, do not write, do not resuscitate, because you cannot write like this. Passive euthanasia is not allowed in India. It is not legal, because in one of the cases which was decided in Supreme Court, that is Aruna Sandbag case, and it is only exception. In this particular case, Supreme Court allowed passive euthanasia, but there are some guidelines also. So in this situation, whenever you face this type of situation, you can discuss with relative, but you cannot mention in your case paper, do not write or do not resuscitate. One more area, transfer of patient. When you are dealing with high risk pregnancy cases or in any complications, you have to transfer patient. So it is again double-edged sword. If it is too early, why you didn't resuscitate and send in case of some acute emergency? If it is too late, why didn't you send it early? So it is double-edged sword. So whenever you take decision of transferring any patient, take collective decision which can be justified in court of law. When to shift? Avoid shifting hemodynamically unstable patient because she may die on the way and you may be in big trouble. It should be in time. It should be at proper place, because you should have inquired about availability of bed, operation theater, ICU, instrument like ventilator, and confirm with right and proper person. Because many a time patient reaches there and ventilator support is required and ventilator is not available, patient will have to be shifted to another hospital and precious time is wasted. So you have to confirm all this. And with escort, you have to escort in the same ambulance, because in the same case of Perin Irani, doctor escorted patient, but in his own car. On the way, patient suffered heart attack and he tried to resuscitate, but ultimately patient expired. And case was decided against doctor because he was not in same ambulance. So you escort patient in the same ambulance with emergency drugs, IV fluid, oxygen cylinder, etc. And if treating doctor is busy, equally qualified person can escort. An anesthesiologist is the best person. In case of shock, use pneumatic anti-shock garment, because it shows your consent that you have taken utmost care of your patient. And acknowledgement when patient reaches the very particular hospital, take it, give all the documents of treatment given and get it signed by person concerned who have received charge of the patient. Time and date is very much important in this type of situation. And as far as transfer documents are concerned, we do not want to go into detail because this is the checklist and we have to give all the documents to the patient and preserve all the transfer notes which you have submitted to the patient. And on Foxy website, you go with Foxy uniform consent. There are 30 different consent. Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, MC Patel from Ahmedabad. We have prepared 30 different consent, and in those consent, how to transfer patient, which kind of document we have to give to the patient. We have mentioned everything in that very consent. You simply download and use in your day-to-day practice. Let us see story of young junior who had just started his practice. Post-cesarean section, there was sudden breathlessness and it was query amniotic fluid embolism, shifted to tertiary care hospital, died after 4 hours of treatment. Relative made a police case and threatened that they will put a case in consumer forum for 1 crore. Now, question for that very gynecologist, if this case goes against me and court award 1 crore, from where will it recover the amount? So in this type of situation, indemnity is always at your rescue. So should we take indemnity cover? Yes, no, always yes. And it is not only yes, it should be adequate cover. So what to do in this type of all cases and how to prevent? Because every high risk pregnancy cases are potential threat as far as medical legal problems are concerned. So in this type of situation, we have to observe only three things. One is foreseeability or anticipation. We have to anticipate certain complication related to that very case with high risk pregnancy. Say, for example, if it is a case of central placenta previa, naturally one should anticipate that she may end up into PPH, she may require blood transfusion, she may require obstetric hysterectomy also. So we have to anticipate and we should be readily available to deal with the situation. And we have to counsel patient. But whenever you are dealing with any case of high risk pregnancy cases, no rosy picture about result, no tall claim about result, because in our obstetric practice we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, proper communication and proper documentation is always at your rescue. So keep them up to date, what was done, nothing was neglected, given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. Important bills, it is also part of your record. Say, for example, purchase of oxygen cylinder or refilling of oxygen cylinder. Because in one of the cases which happened in state of Gujarat only, there was allegation on part of relative that when patient suffered heart attack, oxygen cylinder in hospital were empty. And we were saved in that very case only due to bill of refilling of oxygen cylinder just 1 day prior. So bill of purchase of oxygen cylinder and refilling of oxygen cylinder is also part of your record. Purchase of defibrillator, ventilator, emergency instrument like ambu bag, and all emergency drugs bill are part of your record, and it will be very much useful if at all you are facing any litigation. And as we know, good record is good defense, poor record is poor defense, and no record is no defense. And it is my experience during my medical legal practice. We doctors are very poor as far as record keeping is concerned. So to conclude with Kerry Holmes, we have to strictly observe with all pregnancy profile, and we have to manage our patient as per standard protocols and checklist, proper counseling and consent, proper documentation, multi-speciality approach, no compromise on statutory requirement, professional indemnity, be vigilant in your practice, comply with provisions of law, formation of local level RUS team or medical legal cell. They are very much useful because in any emergency, any member of RUS team will be available for you for surgical assistance at the time of declaring bad news, in case of assault, in case of medical legal emergencies. So in each and every society, there should be local level RUS team, and take medical legal advice whenever you are in doubt since point one, because these gentlemen have so many staircases, but it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way. And if you want to sleep like this, take tender care of your patient, pray Almighty God before going to sleep, and keep my visiting card below your pillow. Have a litigation free medical practice. With regard, salute to all the organizers. And to end with my talk, with my this request, please endorse my candidature for post of President Foxy election year 2026. Thank you very much. Please do not assume. Please ask if any query, any question, if chairpersons and time permit. Thank you very much.
Thank you, sir, for an elaborate talk. We have Dr. Alka Kute, madam, here. So, madam, please, over for your expert comments, ma'am.
Yeah, actually, sir, I was little late because of some IMA Haldi Kunku program, but I listened to your lecture. It was clear-cut guidelines for in today's era of consumerism, and nicely elaborate lecture by you, sir, as usual. Especially high-risk pregnancy does matter for all of us, because today we deal with each and every patient as a high-risk patient. So not a single patient without risk. So it will be exaggerated to say that every patient is like a potent litigant. We know nowadays we tell like that. Every patient should be like high risk pregnant patient. So in that scenario, whatever you had told, sir, these are the nice tips while dealing with any patient in our day-to-day practice. Especially when we deal with high risk pregnancy patient, we have to take certain precautions as told by you. And high risk consent does matter important as far as defense in medical law court of the any court, whether it is consumer court or civil court. But wonderfully explained by you. Thank you so much, sir, for your wonderful guidance as always.
Thank you, madam.
Thank you, Alka ma'am, for chairing the session, and thank you, sir, for an elaborate talk. So we take a very important key message that documentation is the defense in the court of law, and we request each and every practitioner to document either in written or you have video consents so that we can prove the safety in the court of law. We now move ahead with a very important panel discussion, which is case-based approach in hypertensive disorders and pregnancy. And I request Dr. Shatabdi to please start with the panel discussion. I still cannot see her, so can I start introducing? We have our important moderators, Dr. Sneha Bhuyar madam and Dr. Pranjal Sharma madam, who will be moderating the session. Can we have the CV slides, please? The moderators, please. Darshan.
Please go above. Please go above, not below.
First
above.
slide with the moderator.
Before this. Yeah, yes.
Dr. Sneha Bhuyar madam is practicing since last 32 years. She has been the past chairperson of the Foxy Breast and Puerperal Health Committee. She has been the president of the Yavatmal OBGY Society. She has also received the Dr. S.N. Malhotra Unsung Hero National Individual Award for Outstanding Work in Rural Obstetrics, Dr. Durusha Award for Distinguished Community Services in 2022, Champion of Foxy for 2 consecutive years, and the Dhira Award. She's also received the MS Signature Award. We welcome you, ma'am, as the moderator for this session.
Thank you, Monica.
Yeah. Dr. Pranjal Sharma, madam. The next slide, please, Darshan. Dr. Pranjal Sharma, madam, is the director of Sharma Hospital, Amravati. She is the past president of the Amravati OBGY Society, the zonal coordinator of AMOX from 18 to 22. She has been also the website and publication committee chairperson of AMOX and the organizing chairperson of the AMOX zonal coordinator. We welcome you, ma'am, as moderator.
Thank you so much.
I also invite Dr. Rashmi Kahar Madam as the expert for the panel discussion. She is currently the chairperson of the Practical Obstetric Committee of FOXI and been the past chairperson of the Amravati OBGY Society. She is also the director at Tharodkar Women's Care Hospital. Can we have the next slide? Take a second.
Neha Madam will introduce the panelists. Neha Madam, please.
Okay, so Monica, thank you so much for the lovely introduction. A very good evening to all of you. Thank you, Dr. MC Patel sir, for having all of us here. And I welcome all the panelists, Dr. Archana Rathod from Yavatmal, who is the current president of Yavatmal Obsgynae Society and a very dear friend. Dr. Varsha Chauhan, the past president of Yavatmal Society, of course, a very dear friend. And both of them are academically very well known and practicing in the city since so many years. So I think with this, I would ask Pranjal to introduce her colleagues from Amravati.
Thank you, Sneha Madam, for your kind words.
Yes, thank you, MC Patel sir, for giving us opportunity. Now let me introduce you to Dr. Jagruti Shah. Madam is a senior OBGYN from Amravati, who I am very sure has closely witnessed the changing trends in the management of HDP since last 3 decades. She is superbly enthusiastic persona, serving as a guiding force with every team of Amravati, may it be sports, may it be cultural or academics. Welcome, ma'am. Dr. Saili Zahagirdar, she is Associate Professor, OBGY Department, PDMC, with outstanding academic background. Her strong foundation in research and evidence-based practice reflects her commitments to her profession. Her zeal to complete the task given is simply unmatchable. Welcome, Saili. Dr. Manjushri Boob, Madam, she is a respected senior member with extensive experience and deep clinical insight. Her leadership, professionalism, and commitment to excellence continue to inspire everyone around her. Dr. Apurva Mundra, she is a new bright star on the horizon of Amravati OBGY Society, soon to shine at national levels. She is enthusiastic and dedicated, known for her eagerness towards every commitment and positive approach to every responsibility. Welcome, Apurva.
Can we have the next slide, please?
Then I can introduce Dr. Keshwani and Dr. Meena Agarwal, Madam from Pusad, ma'am.
Yeah.
Am I audible now? Because I think I lost connection in between, ma'am.
Yes. Go ahead, Monica.
Dr. Meena Agarwal, Madam, has done her DGU from Indira Gandhi Medical College, and she's practicing since last 33 years at Pusad Hospital. She has was the past president of IMA Pusad and the past president of Pusad OBGY Society. We welcome you, ma'am. We also have one more panelist, Dr. Keshwani, Madam. Dr. Neeta Keshwani, Madam, has been the ex-registrar at VNGMC Avatmal. She's practicing since last 18 years, and she is the director of Keshwani Hospital at Yavatmal. We welcome you, ma'am, and over to our moderators, Dr. Sneha, Madam, and Pranjal, Madam, for the panel discussion.
She is also the past president of Yavatmal
OBGY Society.
Thank you, madam. And we're very happy to have such an illustrious panel, who are senior, well-experienced consultant obstetrician gynecologists. So may we go ahead with the panel discussion without much ado. So friends, all of you know that hypertension, hemorrhage, and sepsis, these are the 3 major killers of women. We do have so many predictive factors, including the maternal characteristic, that is the maternal age, BMI, and of course the maternal medical illnesses like hypertension, diabetes, hypothyroidism. Also, we do have the biophysical and biochemical test, but in spite of all this, we are not able to, screen the women and detect or rather predict who is, prone for hypertension. We do have certain preventive strategies like low dose aspirin and high dose calcium vitamin D. In spite of all this, we are still having high maternal mortality and higher incidence of HDP. And that's a very reason, friends, have a look at this, what the Professor Mohammad Fatala, who is the past president of FIGO, has said. Women are dying not because of the diseases which we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. So, friends, let all of us decide to save our women. I'm sure all of you are well versed with this. The basic pathophysiology of PIH or HDP is the failure of the trophoblastic wave of invasion. I'm sure you have listened to the previous lectures. And because of this failure, so what happens is the spiral arterioles, they become converted into permanently dilated channels. So this failure of this conversion results into the vasoconstriction and the fetal ischemia, or rather the placental ischemia. So on fetal aspect, you have FGR, and on maternal aspect, you have these various changes. If it is left untreated, that leads to severe preeclampsia, eclampsia. So without much ado, we go ahead with the first case. We start from Dr. Varsha. All of you
Yes,
know
madam.
she's a senior consultant obstetrician from Yavatmal. So Varsha, this is a lady who has come to you in your OPD. She belongs to a low socioeconomic status, and she doesn't have any medical illness previously, no significant medical history. She's booked and she has had an uneventful course up till now. So at 32 weeks, when you examine her in OPD, her blood pressure is 140 millimeter of mercury. So the question is very simple, whether you would label this patient as hypertensive.
Madam, first of all, she is a case with the age of 22 years, primigravida from a lower socioeconomic status. And at 32 weeks, for the first time, she has a recorded blood pressure of 140/90.
Right.
So first of all, I'll ask her to wait, again recheck her blood pressure, take a detailed history of all the symptoms, family history, examine her properly, whether she has edema fit, whether she is corresponding to 32 weeks of period of gestation, or whether she has IUGR confirm, and send her
Yes,
for the
yes, yes. We will go
investigations
to the
and
management
biophysical
later on,
profile.
Varsha. The
Yes,
question
madam.
is whether you will label her as hypertensive.
Madam,
No, madam. I think I will repeat check her blood pressure after half an hour, and at least two readings of 140/90, which are taken at the apart of 4 hours. Then
Correct.
only we can label that she has a hypertensive disorders of pregnancy,
Perfect.
along with if she has edema and proteinuria.
Yes, perfect.
Yes,
Very
ma'am.
well said
Yes,
that
ma'am.
it should be 2 readings, 4 hours
Yeah.
apart. Now
4
you
hours
just
up.
let me know, the patient is coming from a distance. She's just rushing and coming to your
Yes.
OPD. Immediately, she's going inside. That time her BP must be raised. So what are the prerequisites for taking a correct blood pressure rather?
Basically, madam, we should give her the proper position. The blood pressure cuff should be of proper size.
Right.
Then it should be at proper at heart level. And then definitely we should measure it properly.
Right.
And only one reading of high blood pressure we cannot label her as a hypertension.
Yes. And the
Yes.
patient also should be physically and mentally relaxed.
Relaxed.
She should
Yes,
be,
ma'am.
yes. Anybody else wants to add to this?
Patient should be empty the bladder.
Yes, perfect. Anything else?
And leg should not be crossed.
Anything else? Good.
Madam, proper cuff size. The sphygmomanometer should be proper.
Yeah.
Patient should be in a sitting position. At the heart level of the patient.
Yes, yes. The Dr. Varsha has said it that the blood pressure should be measured in a sitting position, preferably on the right upper arm. And yes, you can repeat it in the left upper arm as well, but preferably in the right upper arm with a proper size cuff. And the sounds, as all of you know, that Coraco's 1 is systolic, Coraco's 4 is diastolic, but sometimes the muffling doesn't happen. So, the disappearance doesn't happen. So, Coraco's 5, not the Coraco's 5, but sometimes you have to take the muffling as 4 also. And this BP apparatus, it should be well calibrated or standardized. But before that, as I said, the patient should be physically and mentally relaxed. Her bladder should be empty, and she should not have had any medication at least an hour prior to coming to the hospital. Not even the eye drops. Okay, and her clothing should be comfortable. Okay. So that is how you have to see that you are examining the blood pressure in such conditions. Okay. So now that Dr. Varsha, you have said that you have taken a BP 4 hours apart, but meanwhile, do you want to do certain investigations? How would you go ahead?
Yes, madam. I'll definitely do her certain investigations. As she is antenatally registered, her antenatal profile must be definitely done. But because she is at 32 weeks, definitely the screening for because her blood pressure is 140/90.
Yes.
Definitely, I'll at least till the time I'll confirm that she is hypertensive. By that time, I'll ask her to get her PIH profile, at
Right.
least urine for albumin, renal function test, liver function test.
Ah.
And definitely for the fetal well-being, I'll ask her to get one ultrasonography with the Doppler done.
Right.
And by the time she comes with her investigation, again check her blood pressure.
Right.
Definitely, if she has a high blood pressure, then definitely we will go with the management of the
Perfect.
pregnancy-induced hypertension.
Perfect. So now
Yeah.
your patient has high blood pressure, and that is 140/90. So do we label her as mild hypertensive, Dr. Saili? What are the parameters that decide the severity of the blood pressure during pregnancy?
Good
Severity of
evening, ma'am.
hypertension. Yes.
Usually, whenever we see for the first time such a patient who has
Mm-hmm.
a BP of 140/90, we should
Mm-hmm.
see her past antenatal records. She
Right.
must have come regularly for the past 7 months. So, if in those records, if her BP was say 90/60 or 100/70, then
Mm-hmm.
automatically this patient should be labeled
Okay.
hypertensive disorder of pregnancy at present.
Yes.
The other
Basically,
parameters,
basically we have labeled her as hypertensive disorder
yes.
of pregnancy because her blood pressure is 140/90. That is confirmed. You are
So,
very correct. But whether this is mild or severe, how do you decide? What are the parameters? It's not only blood
So
pressure,
only if
something
her
else.
blood pressure is 140/90 and
Mm-hmm.
she has no associated symptoms like
Mm-hmm.
headache, blurring of
Yes.
vision, or oliguria, or
Yes.
pain in the right hypochondrium, then
Mm-hmm.
we would label her as mild HDP. However,
Okay.
if she's having all these other symptoms,
Mm-hmm.
all those symptoms of preeclampsia like headache, visual
Right.
disturbances, upper abdominal pain,
Mm-hmm.
proteinuria, oliguria, then she will come in severe preeclampsia.
Right. So basically, it's not only the symptoms, but also the laboratory parameters. Yes. Anybody else wants to add, Nitu?
Madam, ultrasonography.
Yeah. Before that, the blood investigation.
Blood investigation. We do all blood investigation, and that is a renal function test, liver function test,
Yeah.
and a coagulation profile.
Right.
And also we see peripheral smear, see hemolysis, indication of hemolysis, reticulocyte.
Right.
All these we should
Yes.
see.
So this is a list of investigation which you have enlisted here that we should do all these investigations. But the alarming symptoms, like as Saili has already said, headache, blurring of vision, right abdominal pain, and oliguria, reduction in the amount of urine she has passed, and then of course impairment in the liver and renal function test that tells you about the possibility that yes, it is a severe hypertension, even though the blood pressure reading is 140/90. Mind well, BP is not always a dependable indicator of severity. Okay, that we have to keep it in mind. Yeah. So as all of you know this, why do you do the investigations? Anybody can take up this. Nitu, you can continue with this in short.
Madam, we will do complete hemogram, that is CBC, in which we see platelet count, and urine examination, albumin for urine albumin, your liver enzymes. If liver enzymes doubles, then it is more severe.
Yes.
And renal function test, creatinine. For this severity, we should urine creatinine should be around 1.2 for
Right.
this patient.
Yes.
And platelet count, serum electrolytes, and we see the peripheral blood smear for hemolysis, which will show fragmented RBCs, spherocytosis, and reticulocytosis. And also we do fundoscopy for this patient for the these changes.
Right. So for complete evaluation of this patient, we should do all this investigation, as all of you have very nicely, enumerated, and you have justified why you are doing this investigation. So we come to Dr. Manju. I think Pranjal can take up from here. Pranjal, over to you.
Yes. Manjushri madam. Is Manju madam there?
Yes, I'm there. Am I audible?
Hello. Yes, madam, you are audible.
Hi.
Yeah,
Hi.
hi, Manju.
Yes.
Madam,
And at the
in such
outset,
scenario,
I would like to thank everyone for making me a part of it.
in such scenario, when you would like to start the antihypertensive to this patient?
Uh, Ideally, mild to moderate hypertension, as we say, according to ACOG recommendation, if it is between 140, 90 to 159, 109. Ideally, we should not immediately start any tablets. We have to do a very good maternal and fetal surveillance. Maybe as an outpatient, maybe we can have a daily BP record of this patient and then decide whether we have to start. But practically, I would really like to add this is a red flag to me. At 140/90 only, I'll think that it is not normal. And as Siley said, that previous records were just 120/80, 110/70. And if she is making 140/90, it is not mild to me. It may be a red flag, and here we need to think of antihypertensive along with all other things. Definitely, mild hypertension, we need to have a very good surveillance. And if we go according to WHO, am I clear?
Yeah, I think you have two devices on. That's the reason it is echoing. You can
Okay,
put off one, the mobile.
just a minute.
Pranjal,
Yes, ma'am.
You can make some comments meanwhile.
So, Apurva?
Yes, ma'am. Anybody wants to differ from this, that you should not start antihypertensive from one.
Can I carry on? Can I carry on?
Yes,
Yes, ma'am. Yes.
Am I audible? Yes.
Yes, ma'am.
Yeah. So with 140/90, definitely it warrants an antihypertensive drug clinically and as WHO has also recommended. But if we go by AOCOG guidelines, they said that mild to moderate hypertension, you should not start antihypertensive. But definitely, FOXY guidelines are very proactive. They don't want patient to have a severe hypertension and then think of starting drugs. So, for mild hypertension and moderate hypertension, along with a proper medical and fetal surveillance, we would like to start with oral antihypertensive drugs like labetalol.
Perfectly categorized, madam. Red flag is certainly necessary, or you can put some red dot on her card so that routine surveillance is necessary.
Yes, so I would just like to make a comment here. Previously, all the guidelines, they used to say that you must start antihypertensives only when the BP goes above 150, 100. When we were the resident, that was more than 3 decades ago. Since last 2 decades, most of the organizations have changed, including the World Justice Organization, who is the authority of this subject. So FOXY ICOG also recommends that systolic of 140 and diastolic of 90 millimeter of mercury warrants the use of antihypertensive drugs. I'm sure all of you have witnessed a patient who is having 120/80 prior, even post-delivery, if she has 140/90, she can convulse.
Yes.
Right.
Surely.
So blood pressure is again not the dependable parameter of severity. These are the investigations, what is the end organ damage it has done. That decides, and that's a very reason if you have 140/90, you have to start with antihypertensives. And nowadays you have, all the other classifications have gone. It's only the clinical classification of severe and non-severe. Okay, so with severity parameters positive, it is severe. With severity parameters absent, it is non-severe. So whenever you have 140/90 along with severity parameters, in fact, it warrants you to treat it as severe hypertension, right? You can go ahead, Pranjal.
So now, as we all know, since last decade, we are using labetalol. Why labetalol, Dr. Apurva Mundara?
Yes, it is the drug of choice. Actually, it is both alpha as well as beta antagonist. So, because of alpha selective antagonist, it helps in vasodilation of the blood vessels, and because of beta antagonist, it helps in control of the heart rate. Though keeping the cardiac output good, I mean good cardiac output. So that is why it is the drug of choice in pregnancy, and the dose should be 100 milligrams twice a day initially, which can be increased to thrice a day. And also like the dose can be increased to 200 milligram twice or thrice a day. The maximum dose will be up to 2400 per day in divided doses. The blood pressure should be monitored every after starting that, and then depending upon if the control is good, then she can be continued on that dose.
Any side effect noted which needs monitoring or something?
Yes, side effects will be like bronchospasm. So in cases of asthma, the patients better to have to keep in mind for bronchospasm.
Perfectly said, Apurva.
Even, madam, the patients who are having the low pulse rate, if it is less than 60,
Then we
I
can
think
switch. Yes.
then I think we should change the
Switch
drug.
over to yes.
Switch
Yes.
over to nifedipine. Yes.
So basically, you have a patient whose blood pressure for the first time is 140/90. You have checked it with proper, eligibility criteria. Now you have labeled her as hypertensive. You have seen that whether she has severity criteria, this was not done by the obstetrician. So this patient, she thought it is mild hypertension, right? So she just explained the patient and sent her home. If at all you get any problem, you have to come back for follow-up. Okay. So otherwise, what is our aim from here? How do you monitor and manage this patient? You have already labeled her as hypertensive. So how do you monitor the maternal well-being and the fetal well-being?
We need to do weekly PIH profile test, as well as Doppler of the USG Doppler should be done to assess the fetal growth and the Doppler blood flow to the fetus. And non-stress test can be done after 34 weeks of gestation, twice a week. And Doppler should be done every weekly, unless and until there is raised umbilical artery, diastolic flow is raised. So that time we need to monitor.
Yeah, PA. So, labetalol you have already answered. Pranjal?
Yes.
You can go ahead.
So, those who are practicing since last 2 decades or so, they know that alpha methyl dopa used to be the favorite drug. Rather, it used to be the first line of treatment. So, Dr. Meena Agarwal, madam, why not alpha methyl dopa now?
So when we were learning in the college, we used to give alpha methyl dopa, but nowadays better alternative is available, like labetalol and nifedipine. And because of alpha methyl dopa side effect like hepatotoxic, slow action, and drowsiness, we now you use better option for it. That is labetalol and nifedipine. And it is some study shows that alpha methyl dopa can cause fetal growth retardation. That's why we ignored nowadays. It is ignored drug, and as better option is available, we use labetalol more frequently.
I think everybody will agree that alpha methyl dopa is not available in the market. That is the
not
first
available.
Yes. And then, of course, I'm sure all of you, we are from the same generation. I think you must have used it. Alpha methyl dopa
250.
2 QID, first day. So the onset of action was so delayed. It was at least 24 hours. And next day, suddenly the patient will have postural hypotension. So these were actually sedative effect, drowsiness. Then also she had, postpartum also she had, postpartum blues and depression. So all these problems, along with this thrombocytopenia, even non-reassuring fetal patterns. So all these were quite common, and that's a very severe headaches, which we think is mostly because of nifedipine, because that time we used to combine nifedipine and alpha-methyl dopa. So that also confuses you with the preeclampsia or immunoeclampsia, and that's a very reason this drug is not being used nowadays. Though those who love it say that if it is available, we would like to use it. I'm sure many of you must have witnessed this.
Dr. Neeta Keshwani, throw some light on role of bed rest, salt restrictions, or any lifestyle modifications.
As we know, pregnancy requires increased plasma volume, and some evidence shows that a low intake of salt will suppress the renin-angiotensin-aldosterone system, and this will also this will depress the placental perfusion. And this placenta, due to this, there will be the increased chances of HDP. So there is no role of benefit from salt restriction. At normal routine salt intake is feasible, but extra salt should be avoided. And some preparation which are using excess amount of salt should also be restricted, like pickles and papad. And there is no role of bed rest in this HDP, as there is no improvement in maternal and the fetal outcome, improvement in the fetal outcome. So in fact, they increase the chances of the thromboembolism. So there is no role of bed rest and the salt restriction.
Yes. So, friends, challenges are what makes life interesting, and overcoming them is what makes life meaningful. That is how it has been expressed by Joshua Marin. So, this obstetrician was from our old generation. She just thought it is 140/90, kuch nahi hota, chale jao, kuch problem hua to aana hai. So, 5 days later, the patient was brought to the hospital with severe headache and nausea, upper abdominal pain. When you examined Varsha, BP was 170, 110.
Yes, ma'am.
Reflexes were brisk and epigastric tenderness. So, what is your diagnosis and how will you manage this?
Madam, definitely now once the blood pressure is 170 with 110 millimeters of mercury with DTR brisk epigastric pain, she definitely has a hypertensive crisis. And definitely she needs a emergency admission. And once she has been hospitalized, definitely she has to be taken care of her blood pressure. We have to control her blood pressure, examine her properly, do all the blood investigations again, including her renal function, liver functions, coagulation profile, arrange the blood, keep it ready. And definitely we have to secure a IV line and definitely treat her as a case of severe preeclampsia. And the another aim is to prevent the convulsion. So definitely we may have to start with the magnesium sulfate. And but before starting this, we have to definitely confirm whether the patient, the treatment which we had given, whether she was regularly taking it or not taking it, because most of the times we find it, madam, patient takes the medicines only for 4 days and they don't even continue with antihypertensives, and that is the main reason why they land up with the severe hypertensive crisis.
Right.
So, yes.
Now, one more reason to divert this discussion little away from this management going ahead. 32 weeks only. Severe
Yes, ma'am.
hypertension, that is hypertensive crisis. On one hand, you have to see that the patient doesn't convulse, and on the other hand, you have to make sure that she doesn't have severe hypertension leading to abruptio. So you are giving her antihypertensive, which is effective. We will discuss it later. But
Yes,
whether you want to terminate this pregnancy or no immediately, how do
No,
you
no, madam.
decision on
Definitely, I'll give her antihypertensive. With the antihypertensive, if her blood pressure is well controlled, get her ultrasonography done, get her NST done, and if the fetus is fine, the liquor is fine, and with the good antihypertensive control, if her blood pressure is controlled and her all the impending signs of eclampsia, if they are controlled, then definitely I would like to give her betamethasone, because at 32 weeks, thinking of termination, definitely the baby will end up with the prematurity.
Yes,
But
but you have
suppose
to
if in
take care of
spite
the
of
mother
giving
also.
antihypertensive,
Yeah.
if her BP is not controlled and she continues to have signs of impending eclampsia, or if ultrasonography shows any changes of severe oligohydramnios or ultra Doppler changes, or if the NST is not good, then only
That
we
is,
have to think.
yeah, Varsha, just let me explain. That is, you're talking about the fetal aspect mainly.
Yes, madam.
But when you have sent the laboratory investigations, we
Yeah.
have to see that there is no end organ damage, there is no
Yes.
liver function impairment, there is no renal function impairment, because you are trying to push this baby pregnancy go ahead, but at the same time you have to make sure that she is not landing up into hepatic failure or renal failure, or
Yes.
she may convulse or go into abruptio. Okay.
Yes,
So
yes.
we have to make sure that she is not having end organ damage. So the
Yes.
patient who has signs or laboratory parameters suggestive of end organ damage is labeled as hypertensive emergency. And she
And we need
to be delivered as soon as possible. That is
Possible.
when she is controlled or stabilized. On the other hand, if she has only severe hypertension, once the blood pressure is controlled and all her investigations are within normal limit, we can take this pregnancy ahead. That is how the decision making is.
Yes,
Why are you worried about the severe hypertension? what complications can occur if the
Madam,
blood
she
pressure
can
is
land up
too
with
high.
the eclampsia, she can land up with the stroke, she may land up with the hepatic rupture, disseminated intravascular coagulopathy, she
Right.
may land up with pulmonary edema and cardiac failure, unstable angina, she may land up with even renal failure. These are
Perfect.
all the maternal complications, even the myocardial infarction and eclampsia. She may land up with all these complications.
Right. So basically, her vasculature is not adapted to all this very high blood pressure, and that's a very reason our aim should be to control the blood pressure to a safe level. We will go to the details little later, but I would ask Archana, what are all the drugs that are available for management of such severe hypertension, and which one do you prefer?
When a patient presents with severe hypertension, the care is taken to control the hypertension as well as to prevent the eclampsia.
Yes.
So the drugs which will control the hypertension will be routine antihypertensives like nifedipine, which will give you rapid control of hypertension.
What is
Then
the
we can
dosage? What is the dosage for oral nifedipine?
5 to 10.
nifedipine should always be
10
given
mg.
per orally. To start with, we can give 10 milligrams of nifedipine, and we can repeat blood BP monitoring after 10 to 20 minutes. If
Yeah.
patient responds, then
After oral, let me ask you just for the information of the house, within how much time you feel that the blood pressure will be controlled by oral nifedipine?
see, at least we will for control we will give repeated doses, but the action of nifedipine will take 20 minutes if the patient is responding to the nifedipine.
Okay,
If
so
he is
the
not
onset of
responding, we'll have to increase the
yes.
dose of nifedipine.
Okay, so the onset of action starts within 5 to 10
minutes.
and the peak action is at 30 minutes.
30 minutes.
The duration of action is 6 hours because the plasma half-life is 6 hours, right? So oral nifedipine, the orange color capsule, 10 milligram given, orally. Once again, I'm saying oral is a very good option. But what is the drug preferred nowadays or available nowadays in addition to all the drugs, Archana? What are all the drugs for such severe hypertension?
After nifedipine, if it is not getting controlled, then we can think of intravenous labetalol. Because oral labetalol will take certain time for acting. So we can give 20 milligram of IV bolus to the patient if she is not responding, and then we'll repeat blood pressure again after 20 minutes, and we can administer 40 milligram IV labetalol later on. The maximum dose should not exceed more than 220 milligrams of IV labetalol.
Right.
If patient is not responding to labetalol, then we can consider hydralazine as a parenteral drug which will control
just
the
to interrupt you
hypertension.
little later, to sum up, labetalol you give 20, 40, 80, and even if this is not responding, repeat 80 again. Okay. So, but then if at this stage it is not responding, that means how much time do you give every time? You give at least 10 minutes for the desired effect, right? So if you don't get the desired effect within 10 minutes, you can repeat the next dose because you don't want your patient to convulse or go into stroke, right? That's a very reason you have to act promptly. About hydralazine, how do you use it? What is the dosage schedule?
Hydralazine can be used 5 to 10 milligram IV over 3 to 5 minutes slowly. And again, we'll monitor the blood pressure. And if it is still high, we can give repeat dose, but not to exceed more than 30 milligrams.
Yes. And for hydralazine, you need to wait for 30 minutes. Okay. Because otherwise the patient goes into hypotension. Hypotension is the major complication for hydralazine. Yes, you can go ahead. Pranjal, you want to take up from here?
Yes, we have clear cut given the message that nowadays never sublingual nifedipine, and the drugs we should always keep on checking in our emergency rooms or OT or labor room that labetalol is available all the time with us. So this is the message we should take with us. So what are other clinical signs and symptoms investigation you would warrant the termination of pregnancy? So we have discussed all the nifedipine and all we discussed. So during this expectant management, what are the situations that demands termination of pregnancy, Dr. Saili?
Now, this patient is 32 weeks with severe preeclampsia, almost on the verge of having impending eclampsia. So first, I would like to do her blood investigations which would tell me whether this patient is having end organ damage or she's only having an hypertensive crisis.
Right.
If she's having only an hypertensive crisis, I would like to give her IV labetalol or nifedipine and bring down her blood pressure. If there is no end organ damage, then I would like to give a betamethasone at least up to 33 or 34 weeks. But if there is end organ damage, then we have no other option but to terminate the pregnancy. But if the end organ damage is not very severe, we can still give betamethasone, wait for 24 to 48 hours. Now, to decide on termination of pregnancy, we need to do ultrasound along with Doppler of the baby. If the Doppler says that the baby has either absent diastolic flow or a reversal of diastolic flow, then without having steroids, this pregnancy can be terminated. However, if the Doppler is borderline normal or there's only a raised PI, then we can still give a dose of steroids and try and conserve it and do monitoring of this patient for the next 2 to 3 days.
Perfect. So you would like to take this patient to a center where the neonatal backup is available.
Yes. In a patient with 32 weeks and you don't know, this baby will definitely is going to require a good NICU care.
So in utero
if we have
transfer.
got a good, yes, I would like, if there's no tertiary care available for this baby, it is better to transfer this baby in utero to a center where all facilities of NICU are available.
So we are trained to do all the things together in such cases. These are the crisis cases. So everything in a shorter time we are going to do. Dr. Jagruti Shah, madam, are you there? Saili, you can take this question. So at the same time, if she is having BP of
prophylactic maxal.
Yeah.
So if the baby is less than 34 weeks, so Maxalf is going to help in 2 ways. One is it is going to give neuroprotection to the baby. That is, it is going to prevent intraventricular hemorrhages to the newborn. And second is going to prevent eclampsia. So it has a dual advantage in these babies. The regimen that we give is we give 4 gram in 100 ml of NS over 20 minutes, followed by 1 gram per next 24 hours. And depending upon when you terminate the pregnancy, suppose if you're going to terminate the pregnancy within 24 hours, then you just stop the Maxelf and then deliver the baby within 6 hours of finishing the Maxelf.
Right. So
here I would like to add on that IV Maxelf is very much available. So we should have some bottles of some IV Maxelf in our OPD places only.
I think here we have included this word prophylactic Maxelf. So
yes,
everybody knows prophylactic means to avoid or prevent convulsions, right? But
yes.
then why this word has been so catchy? Why is there any change or difference in the dosage or regime? That is what the very essence of this question. What do you mean by prophylactic? Yes.
Prophylactic Maxelf we for eclampsia. So the dose in this can be given as even 2 gram intravenously. But when you talk of prophylactic Maxelf for the neuroprotection, we still continue to give 4 grams.
It was difficult to move a big box.
In fact,
comparison to a small box of the same material, because the frictional force is more for the big box.
Can you mute all others, please?
আবার বলো।
Shatabdi. Okay, I have muted her. So actually the World Justice Organization has very clearly stated that prophylactic or therapeutic, the Maxelf regime is the same. Okay, it's only the name which is to prevent and to treat. Okay, the dosage schedule is the same as pre-charged Maxelf regime, the complete one, and even the Zuspans which we are giving for neuroprotection is in fact the complete dosage and complete 24-hour regime. That is what we wanted to tell you. What we are talking about, what Dr. Saili is saying, is called as low dose Maxelf. That is called as Sardesai's regime. Okay, so that is 2 gram. So this all of you know this Maxwell Pritchard's regime and Zuspan's regime. I don't think we have to go through the theoretical aspect. Dr. Saili has already talked about the Zuspan's regime and how we should continue for 24 hours. Dr. Manju, when you're managing such patients, how often do you repeat the investigation? Your patient is already labeled as severe hypertensive. How often do you repeat the investigation, and at what gestational age would you deliver her? Do we have Dr. Manju? Otherwise, anybody can take up. I think who else is there? Dr. Meena?
Archana madam, Meena madam.
We like to repeat investigation, this LFT and kidney function test after 24 hours if we are waiting for the delivery. And this platelet count I will like to repeat after 12 hours.
Yes. Any difference of opinion? Dr. Archana, Apurva?
If the investigations are okay, there is no end organ damage, then that can be repeated after twice weekly, after 7 to 2 hours.
Yes.
And then Doppler also should be done if the Doppler, there is no end organ, I mean, there is nothing, the umbilical flow is good, then it can be repeated after a week.
Yes. So if there is no derangement in the liver or renal function test or even the platelet count, we need not worry. We can repeat it maybe twice a week. That is every third day. Okay. But if in the initial investigation itself, there is derangement in the liver and renal function test, then you definitely need to repeat it at least over 24 hours. Right? So that is how you have. Of course, when you have such patients with severe hypertension, if the patient, when do you want to deliver her? So what is your aim? All of you, anybody can answer. This is an open question because that you are doing it in your practice day to day.
She should reach up to 37 weeks of gestation. At least 34 weeks. If she is less than 34, then at least 34 weeks she should reach if she is a case of severe preeclampsia.
Okay. If now, why do we have this if? She is a case of severe hypertension, right? So she's with you under treatment. So how do you proceed? Let me know. I got your point. Yes. Our first target should be 34 weeks, right? She's severe hypertension. And once your patient is stabilized and her blood pressure remains stable, her investigations are within normal limit, maybe you can take every third day you are going, day by day ahead, because every one day you are keeping the baby in utero will save at least 1 week of NICU stay, right? That is what is most important. So your first target will be 34 weeks. But if at all you have your patient stable, all the investigations normal, even the baby is growing well and the baby is not going for any worsening of the Doppler parameters, you may try to continue up to 37 weeks. But to be very practical, for severe hypertension, it is practically not possible. So our aim should be to reach by 34 weeks. Okay. Pranjal, you can go ahead.
So before that, a question, anyone who want to take any other, if there are some serious hazardous side effects of Maxel, if you are noting during monitoring, any other drug anyone has tried or some studies from 2022? Is injection levetiracetam. It has got promising results without the side effects. There are nice studies without any side effects. Safety profile is much higher. So many people, they have used this in almost 60 to 70 cases. The study has been done. So levetiracetam is another in our armamentarium.
Yes.
So
I think, Pranjal, very nicely you have brought up this point that basically, in fact, we have lot of points here for Maxel that all of you are using this drug day in and day out. But then if at all your patient lands up into not exactly toxicity, but suppose when you are monitoring, all of you know that you are monitoring her respiratory rate, deep tendon reflexes and urine output. But at any point of time, if at all you find that her reflexes are absent, how do you go ahead with the Maxwell regime? That is one question. I think practical 1 or 2 question, and then we will.
Yes, if we are if there is a kind of any point of any point of time we see that there is a toxicity, we should withhold the next dose of Maxilf in case of Richard regimen, and then again monitor. If suppose there is no toxicity, we can give the scheduled next dose of.
So if
or either you can shift to levetiracetam.
Yes. No, in fact, if it is only absent reflexes, you have to keep only that particular dose. And next 4 hours when you're monitoring, again you check for the reflexes. If the reflexes are present, you can continue with the same routine. But if there is absent reflexes once again, then you have to abandon. You have to withhold the dosage of Maxicid. But if at all you have respiratory depression, then of course you have to give what is called as calcium carbonate, which is the antidote for this. I'm sure we don't have laboratories which do Maxilf levels, so magnesium levels. So that's a reason we have to be clinically
alert,
judging the responses, right? And one more point I wanted to ask: suppose your patient convulses in front of you. So all of us are using Maxilf. So pre-charged Maxilf, suppose we are giving it every 4 hours. But then initially when you have pushed the initial loading dose of 14 grams, within next 10 to 15 minutes, your patient convulses. Then what do you do? Anybody? Varsha?
We can repeat 2 grams.
2 grams.
Anybody else? I will ask all of you. Then we discuss.
No, we should not repeat actually Maxilf, but like other things we should monitor like airway, breathing, and circulation.
Yeah, that we are doing already because she's already
If she is convulsing.
I have told you
and
that.
definitely we can give levetiracetam.
Anybody else wants to differ from this? Basically, magnesium sulfate takes at least 15 to 20 minutes to start its action, right? So the patient, if she is already hyperstimulated, she can convulse for within first 10 minutes. Okay, so even after giving the loading dose of 14 grams, if at all your patient convulses within first 10 minutes, that should not worry you at all. Just keep monitoring whatever you are doing. But if at all she convulses after 20 minutes or 15 to 20 minutes, then you have to repeat with 2 grams. Okay, you have to repeat. And suppose in spite of that 2 grams, additional 2 grams, she's convulsed again, then of course you have to think that maybe there is some neurological cause. So repeated convulsions even after full dose of magnesium sulfate and repeat dose of magnesium sulfate indicates that she may have some neurological issues. Secondly, if she has of course, the other neurological deficit, if at all you have focal neurological deficits, if she has status epilepticus, all these are indicators that maybe she is having some neurological problem, maybe stroke at the same time she has faced. And that is why that's a reason you have to consult the neurophysician immediately. And then, of course, the choice of drug remains levetiracetam for such patients. So that is how I think if at all you want to neonatal, of course, the neonatal care will be taken by the neonatologist, but we have to make sure. And what anesthesia do you prefer? Suppose such patients, her cervix is not favorable, you need to go for then what anesthesia do you want to use?
Regional anesthesia, epidural or spinal?
Yes. So for our answer will be let the anesthetist decide. Okay, then but definitely we would like to prefer the regional anesthesia, preferably epidural, because all of you know that for general anesthesia, the oozing, the bleeding will be more, even the uterus relaxes more and more. So such patient who is already maybe having low platelets and already Maxilf is having some relaxant effect on the uterus. So such patients are more prone for bleeding, oozing, and even postpartum hemorrhage. So we have to prefer regional anesthesia preferably. Though, some old school of thoughts, the anesthetists used to prefer general anesthesia because they have everything in their hand. They say that GA has a better control. But as an obstetrician, it is regional anesthesia that is more, I think. So just to cover few points, I would say this patient was having severe pain, severe headache. When you examine, Dr. Varsha has examined 170, 110. We have all have managed her now severe hypertension. So maybe some had preferred IV labetalol. The newer generation is well versed. All oldies, we prefer capsule nifedipine 10 milligram. So the patient is now, getting her blood pressure down, but she has persistent headache in spite of all these things. So suddenly she was already having abdominal pain. When we examined, her uterus was tense tender, fetal heart going down to 110, 120, and she has fresh bleeding. What is this complication? How do you manage this?
Abruptio
Madam,
placenta.
mostly she has the abruptio placenta.
Yes, yes.
So definitely it has to be treated as an emergency
Yes.
because her coagulation profile is very important. We
Yes.
have to keep the blood ready because only 2 centimeter with the drop in the fetal heart, we cannot wait for her to have a vaginal delivery because
Right.
she's a primary. We
On
will
top
have to
of
take
that,
her
her
for a
coagulation profile is impaired. Okay.
Yes.
Yeah.
okay.
So
Yeah,
what is
so
this?
definitely she has to be taken up for a cesarean section with explaining the risk to the relatives of PPH and DIC and even end organ damage. Because of abruptio placenta, she is again more prone for renal failure and DIC. So we
Right.
have to keep the fresh blood ready, the fresh frozen plasma, the platelets ready. We have to take the high risk consent, and preferably we have to take her at as a multidisciplinary approach. Basically, we have to arrange for the neonatologist, preferably the physician. If he is there in the OT, definitely will take care. And we have to take all the precautions to prevent the postpartum hemorrhage, mostly the atonic PPH, because the patients who have got abruptio placenta, they are more prone for the atonic PPH. So we all know that as soon as the baby delivers, we basically start with the pitocin, nowadays carbitocin. Then we generally, before delivering the baby only, we keep the misoprostol because it works very well.
Yes.
And if her uterus is not controlled, then we have to take the other measures. We have to give her other drugs to manage. And if at all she lands up with, in spite of giving her all the drugs, with atonic PPH, then definitely we have to explain it to the relatives, and even the surgical obstetric hysterectomy. Before that, we can try the uterine artery ligation or the internal iliac artery ligation. If it is not controlled with that, may land up with the obstetric hysterectomy with the internal ilia.
A
So
small
the
addition, Varsh.
explanation to the relatives before taking up such a patient for a surgery is very important, because we never know after delivering the baby what complications she will land up with. So sometimes if we take her patients with a setup like us, we may have to shift her to the ICU or the tertiary care center, for which the relative should give the consent before taking up the patient.
Yes,
A
very
small
well
addition,
said.
role of injection tranexamic acid, 1
Yes.
gram before induction or
Yes,
before anesthesia.
Yes. So basically, otherwise very well explained. But let me tell you, Varsha, in continuation, what you have said, already her platelet count is 50,000. Already the FTP is present and fibrinogen is low in this patient. So you must take an informed consent. You have to explain this patient
that is very important.
before taking her
Very,
to
very.
even OT. Okay, so blood and products, you keep everything ready. You get your senior colleagues or junior expert colleagues and keep the team ready. And then of course, obstetric HDU or ICU, you may need to shift her. You may give them a choice to shift to the corporate hospitals or
Higher center.
disciplinary team if at all you have it available. But I think everything has to be documented on paper. It shouldn't be that we have explained you. Okay, so informed written consent. So this patient was, given informed written consent, and she was managed properly. She was taken for cesarean section. Baby is also good, but this patient had persistent headache in spite of having good and hypertensive control, and she never relieved of her symptom of headache. Even post-operatively, she had severe headache, so she was taken up for MRI, and on the way she convulsed. So this was the MRI picture showing the white matter, the vasogenic edema. Okay, high signal intensity, bilateral parietal region she had. So this is What is this? PRESS.
Press.
Posterior reversible encephalopathy syndrome.
Okay.
And what is the good point only for this? How does this patient present? Severe throbbing headache
Severe
and
headache, and sometimes even they'll end up
Confusion.
with visual disturbances, madam.
yes, blindness.
Yes, visual disturbances they have. So basically, here comes the role of a neurophysician. Definitely, we should take a opinion of the neurophysician.
Right.
And generally, they advise IV mannitol at the role of steroids, madam.
Hmm.
To basically reduce the cerebral edema.
Right. So
Yes, madam.
the good point of this is once you confirm that it is PRESS, then you are, sure that yes, your patient is going to recover well. Otherwise, blindness due to retinal detachment is the worst thing can happen. But
Yes.
if this is because of PRESS, you can conceal the relatives that this is a self-limiting disorder, and within a week or so, she will recover completely. Okay, so that is the good point of this. So though there's no neurological manifestation after 7 days. So friends, crisis is integral to human life, but those who timely and appropriately contract it will survive and succeed. That is what Gita says. So I'm sure all of you have such experiences and all of you have countered it well. So we have survived this world, So thank you once again, all of you. Thank you, all of you, the senior
Thank you.
consultant, for adding value to the discussions. And
Thank
thank
you,
you,
madam.
MC Patel, sir, for having all of us here. Thank you so
Thank
much.
you, Bhuvan,
Thank you.
madam,
Thank you very
and
much.
Thank you so
Pranjal,
much,
madam, for
everyone.
a
Very
very
well.
nice panel discussion. Thank you so much.
Thank you so
Thank you.
much, everyone. All panelists for their
Thank you, sir. Thank you, Patel,
excellent
sir.
inputs.
Thank you,
MC Patel,
Pranjal,
sir.
So
Monica,
Thank you,
big,
madam. Thank you.
big round of applause for both the learned moderator, Dr. Sneha and Dr. Pranjal,
Thank
for
you, sir.
conducting this
Yes.
panel very nicely, and all the
We got to
panelists
learn
also
much more things, ma'am. Thank you so
putting their
much.
inputs
Thank you.
during discussion of a panel with clear-cut carry homes. Thank you, all the
Thank you,
panelists
sir,
and both moderators.
for making us a part
Thank
of
you.
this panel discussion.
Thank you,
And
sir.
best
Thank you.
wishes for
Thank you
your
so much, sir. Thank you, sir.
upcoming election, sir.
Thank you, madam.
Definitely.
Thank
All
you.
the
Thank you,
best,
sir,
sir.
and all the
Okay.
All
best,
the
sir.
best,
Thank
sir.
you,
All the
sir.
best.
Thank you. Thank
All
you.
the
Thank you,
best,
sir. All
sir.
the best, sir.
Yes, thank you.
All the best.
Thank
Thank
you.
you.
Thank you.
This time we will definitely celebrate your victory, sir, as a
Yes,
president of
thank you, madam.
COR.
आपके मुंह में घी शक्कर.
Yes, sir. Definitely.
Thank you all. Thank you,
Thank you,
Sneha
sir.
ma'am.
Thank you, sir.
Thank you
Thank
so
you
Thank you,
all.
much.
Bhuvan, madam. Thank you, Pranjal, madam. Thank you, sir.
Yes.
And thank you all my co-panelists.
Thank
Thank
you.
you so
Thank
much.
you.
I would like to
conclude.
take this
Bye.
opportunity to thank you, our program director, MC Patel sir. Thank you, Monica, our convener. Thank you to my co-coordinators, Dr. Monica Gupta ma'am, Dr. Deepika ma'am, Dr. Nivedita ma'am, and Dr. Megha. Heartiest thanks to Dr. Pushpa ma'am and Dr. Rajesh Modi sir and Dr. Rohidas Chavan sir. All the three talks were excellent. So thank you, Dr. Nitika ma'am, Dr. Monali ma'am, and of course our very own Dr. MC Patel sir. Thank you to all the chairpersons. And last but not the least, it was an excellent panel discussions. Thank you, Sneha ma'am and Pranjal ma'am, Rashmi ma'am, and all the panelists. We extend our heartfelt wishes and best wishes to MC Patel sir for the upcoming elections. Let's hope we all can really celebrate it. Thank you all. We'll see you again
Thank you
next
so
week.
much,
Thank
ma'am.
you.
Thank you
Bye
for the
bye. Thank you
opportunity.
very much.
Thank you.
Enjoyed
Thank you once
panel. Thank you.
again. Good night.
Bye.
Thank you, sir.
We can conclude.
Yes, sir. Thank you, sir. Good night, sir. And it was
Good night.
excellent. Excellent.
Yes,
The today's all the
Yes.
topics and the panel. It was
Yes.
very good. Thank you, sir. Bye.